Good morning. The subcommittee will come to order. Thank you all for joining us this morning. You know, every dollar hospitals spend on inaccurate Medicare audits and appeals or dollars losses should have been used to care for seniors. We're here to discuss the problems facing hospitals today, but also to find solutions that bring sense to our Medicare program and improve care for America's seniors. Today's hearings will examine hospital issues, including those related to CMS's two midnights policy, as well as audits and appeals. This is a bipartisan concern shared by many different stakeholders, the Medicare program itself, and lawmakers on this committee. In order to understand why CMS chose to pursue a two midnights policy, we have to first explore the events leading up to the policy. After we review those events in today's hearing, Congress will be able to make an informed judgment about the merits of the policy and potentially pursue alternative solutions. Our first panel will educate us on the different aspects of inpatient and outpatient payments and services for hospitals. If we want behavior to change and improve outcomes, we need to change the incentives. Our second panel will feature national experts commenting on how federal laws affect everyday medical practice. We'll be hearing perspectives from across the spectrum, providers, auditors, researchers, and beneficiary advocates. As I've talked with stakeholders about current issues in the Medicare program, the two midnights policy comes up over and over again. In listening to a variety of different perspectives, I've come to understand the following. There are misaligned incentives in CMS's inpatient and outpatient payment systems. But hospitals are not doing anything wrong. They're simply responding to the incentives. No matter if a service is inpatient or outpatient, hospitals still use the same equipment and the same medical staff to deliver care. Yet there are two vastly different payment systems, and the systems don't relate to each other in any way. They're based on different coding rubrics, and they pay for different things. And often this is all decided after doctors have provided care. Take, for example, reimbursement for medical education. If the service is billed inpatient, the hospital qualifies for an extra medical education payment. However, if the same service is billed outpatient, the hospital doesn't receive any medical education money. So if you're a large teaching hospital and you could bill under either payment system, why would you ever submit the bill for anything other than inpatient reimbursement? It's all about the underlying incentives. Now let's examine the next piece of the puzzle, auditing. I've heard from hospitals that audits are causing undue burden. I've heard from recovery audit contractors, or RACs as they're known, that they're simply responding to what CMS has defined as improper payments. Their emphasis on short hospital stays is due to, well, you guessed it, the underlying incentives. RACs are able to keep a percentage of any improper overpayments they recoup. Prior to the two midnight standard, there were no definitive rules governing which payment system was correct for short stays. RACs are an important program integrity tool. I think we can all agree. They're focusing on a legitimate discrepancy of Medicare payment. They, too, are responding to the incentives. Although an important tool, auditing also causes unintended behavior changes. We will hear from several of our witnesses today that around the same time the RAC short stay audits were in full swing, there's also an unprecedented spike in outpatient observation services. Observation is meant to be a temporary tool, allowing clinicians to closely monitor patients without using full-blown inpatient hospital resources. However, observation services are now being used as a tool to avoid certain adverse effects, including RAC audits, in some cases avoiding readmission penalties. The saga continues when we turn to the appeals process. Hospitals disagree with RAC audit denials for short stays. As a result, they appeal the decision. Hospitals have found a high level of success at overturning RAC denials at the administrative law judge, or ALJ, level. Same theme, responding to incentives. ALJ equals more likely to have an appeal overturned, so appeal every time. So much activity at the ALJ level has led to an extensive backlog of appeals. Earlier this year, the Obama administration suspended the assignment of new appeals at the ALJ level. Again, we see unintended consequences, denying providers their basic due process rights, occurring as a result of poor incentives. We intended to have a witness from the Department of Health and Human Services here today to testify on behalf of the Medicare appeals process. Unfortunately, Chief ALJ Nancy Griswold was unable to join us, but HHS is committed to briefing the Ways and Means member bipartisan manner on this important topic. At the conclusion of today's story lies the heart of the issue, the two midnights policy. In response to the inpatient, outpatient payment predicament, RAC audits, increase in observation stays, and backlog of appeals, CMS took its best shot at a solution, two midnights. Today we'll hear from all of our witnesses on whether the two midnights solution is solving all or any of the various problems identified in this tale. I commend my colleagues on this committee, members on both sides of the aisle, who've introduced bills that pursue different alternatives to the two midnights policy. My colleague, Mr. Gerlach, along with the original co-sponsors, Mr. Crowley, Mr. Reed, Mr. Roscom, Mr. Kine, have offered a sound proposal for our committee to work from. Before I recognize Ranking Member Dr. McDermott for the purposes of an opening statement, I ask, as always, unanimous consent that all members' written statements be included in the record. Without objection, so ordered. I now recognize Ranking Member Dr. McDermott for his opening statement.
Thank you, Mr. Chairman. This hearing today is really about serving the greater good. When this rule was proposed, the two midnight rule, I submitted on the 22nd of July last year my comments about it, and much of what I thought was going to happen is now here, and we're going to hear about it today. And I'm pleased that you're having this hearing. I'd like to enter into the record that letter so that it gets in the record.
Without objection.
In recent years, hospitals have been asked to do more with less. We have slowed the rate of growth of their payments and asked them to work harder to improve quality and decrease unnecessary readmissions. Furthermore, although Congress just delayed yet again the transition to the ICD-10 classification system, hospitals have had to take steps to move to the new system while continuing to implement the meaningful use requirements and participate in delivery system reform efforts. Many of these activities support the noble goal of improving care for patients that they serve, such as the accountable care organizations and the patient-centered medical home, while reducing long-term costs, but they require upfront capital investments. Hospitals are employing people and providing good and stable benefits for their employees, something other sectors should emulate. Hospitals are doing all of this in the face of a number of regulations and justifiable scrutiny. The administration recognizes the sacrifice this sector has put forward. As an example, the administration has made efforts to reduce the unnecessary regulatory burden. Just this month, the administration released Part 2 of the final rule to reduce unnecessary, obsolete, or excessively burdensome regulation on healthcare providers and suppliers. I commend CMS for walking a fine line between regulating provider conduct and attempting to make these things easier from a burden standpoint. This is the agency's second foray into the ensuring that regulations make sense and they serve a purpose. Unlike some of my Republican counterparts, I believe some level of regulation is necessary to ensure that we protect Medicare's finite resources for future generations. I think everyone in this room would agree that protecting Medicare as a bedrock institution of American life, thereby serving the greater good, does require some sacrifice. This necessary sacrifice must be shared and proportional. To that end, I'm among the first to call for reforms to the Medicare Recovery Audit Contractor Program, and I mentioned the letter that I put in. As a result, I suggest CMS reconsider the policy in this regard. Now, of course, several stakeholders have raised concern that the recovery auditor contractors will be overzealous in pursuing recoveries related to this policy. People knew it when it was put in. It is not that I believe that the RACs should disappear. They perform a critical role in protecting taxpayer dollars, but I do believe that the program needs reform from a fairness and equity standpoint, and I'm pleased CMS has taken some affirmative steps in this regard. I've also been among the loudest voices calling for reform of some of the fraud and abuse laws to allow broad participation among providers and suppliers to participate in innovative partnerships that promote care coordination, such as gain sharing and other shared saving program, while ensuring programmatic protections under the fraud and abuse laws remain in place. I have also introduced H.R. 4658, which would make a modification to the civil monetary penalty law to allow providers to more easily participate in care coordination programs. I've also introduced H.R. 3144, the Fairness for Beneficiaries Act, which recognizes that the 3-day stay often has negative ramifications for the Medicare beneficiaries and would eliminate that requirement. Finally, as the author of the self-referral disclosure protocol provision included in the Affordable Care Act, I have been deeply involved with urging CMS to make certain changes to ensure overpayment disclosures made pursuant to the protocol can be settled in a timely and efficient manner. All in all, hospitals are making shared sacrifices. They're going through a period of unprecedented change. They have demonstrated a willingness to work with us as we move to a new delivery system models, and they have taken some financial hits. I appreciate the work that hospitals do, but also recognize that given the improper payment rate on the Medicare fee-for-service program and the Medicaid programs, they must be subject to some scrutiny by various contractors, including the recovery auditors. I think we would like to ensure that going forward, we will alleviate the regulatory burden where appropriate and ensure that Medicare dollars are being used in a way that sustains the Medicare program for future generations. Hospitals have demonstrated a willingness to work with us as the pursuit of these goals, and I think that we will hopefully from this hearing today be able to evolve some legislation. I yield back.
Today we'll hear from witnesses on two panels. Sean Cavanaugh, Deputy Administrator and Director of the Center for Medicare at the Centers of Medicare and Medicaid Services. Jody Noodleman, the Deputy Inspector General for Audit Services at the Office of Inspector General of the Department of Health and Human Services. And on the second panel, we will have Amy Duschendorf, Senior Director of Clinical Resource Management at Johns Hopkins Hospital Health System, Dr. Ellen Evans, Medical Director of Health Data Insights, Dr. Ann Sheehy, faculty on behalf of the Society of Hospital Medicine, and Toby Edelman, the Senior Policy Attorney, Center for Medicare Advocacy. Mr. Cavanaugh, congratulations on your new position at CMS. The Ways and Means Committee is happy to welcome your first congressional testimony in your new role, and Mr. McDermott promises to take it easy on you. You're now recognized for 5 minutes, and I should say both of those testifying and the members today, we have two panels. We're going to be tight on time. We're going to hold real fast to the 5-minute rule, so Mr. Cavanaugh, welcome.
Thank you, Chairman Brady. As you point out, I just became Deputy Administrator at CMS a few weeks ago. However, I'd point out that I started my career in healthcare in this committee room working for a member of the Health Subcommittee. I have great memories of working in this room with colleagues from both sides of the aisles to improve the Medicare program, and I have deep respect for the role Congress plays and this subcommittee play in setting Medicare policy and doing appropriate oversight of the operations of the program. So it's an honor to return here today to this committee room representing the agency that administers Medicare. When a patient arrives at a hospital needing care, one of the critical decisions that physicians or other qualified professionals must make is whether to admit the patient for inpatient care. This decision is often a complex medical judgment, taking into account the patient's medical history, comorbidities, and other factors. However, as Chairman Brady pointed out, because of statutory requirements, Medicare pays hospitals different rates for inpatient and outpatient services. So the decision about whether to admit a patient has implications for provider reimbursement, for beneficiary cost sharing, and also for post-acute care benefits the beneficiary may qualify for. 2 years ago, hospitals and other stakeholders were requesting that CMS provide additional clarity regarding the definition of inpatient care. Hospitals were growing frustrated with the administrative and financial burden incurred when recovery auditors denied a claim for services after care had already been provided. At the same time, CMS was hearing from its contractors that Medicare was reimbursing hospitals for inpatient care that should have been provided in a less costly outpatient setting. Some hospitals reacted to the scrutiny of auditors by treating more patients on an outpatient basis, often in an observation status. Some observation stays lasted 3, 4, or even more days. This caused problems for beneficiaries because it subjected them sometimes to higher cost sharing under Medicare Part B benefit, and it also disqualified them from the post-acute skilled nursing facility benefit since they weren't accruing the 3 inpatient days they need for that benefit. In 2012, we solicited public feedback on possible criteria that could be used to determine when an inpatient admission is reasonable and necessary. We received a large number of responses, but there was not a consensus around any single approach. Last year, CMS finalized a proposal that's become known as the Two-Midnight Rule. The rule sets a physician expectation-based benchmark for when CMS and its contractors will consider inpatient hospital admission and payment appropriate. CMS, as we crafted that policy, we were seeking to balance several principles that I think many of us share. We wanted criteria that were clear to providers. We wanted criteria that were consistent with good, sound clinical practice and respected physician judgment. We wanted criteria that reflected the beneficiary's medical needs. And finally, we wanted criteria that were consistent with the efficient delivery of care to protect the trust funds. In November of last year, CMS announced a probe and educate strategy around the new standard, in which the MACs are now conducting prepayment reviews on a sample of short-stay inpatient claims from each hospital to determine compliance with the Two-Midnight Rule. Claims for inpatient admissions that are not reasonable and necessary are denied, and the MACs work with the hospitals to educate them on this criteria. As part of this strategy, we also prohibited the recovery auditors from conducting any post-payment reviews of claims for the medical necessity of the inpatient status through March of 2014. We used this opportunity to engage in a dialogue with stakeholders on the Two-Midnight Rule. As we began hearing from stakeholders that more time was needed to understand the policy, we extended the probe and educate strategy through September, and Congress subsequently extended it through March 31st, 2015. We believe these extensions are allowing hospitals time to fully understand the benchmark and for CMS to learn more about how this policy is being implemented and understood by hospitals. In fact, preliminary data suggests that as a result of the Two-Midnight Rule, the proportion of long outpatient stays is beginning to decline. However, in recognition of the continued calls from stakeholders for additional clarity around short stays, this year CMS is soliciting public input on two related issues. First, we solicited comment on the advisability of creating a Medicare payment policy for short-stay inpatient cases. Specifically, we requested public comment on how to define short stays and how an appropriate payment might be designed. These comments are due to the agency at the end of June. Second, we reminded the public that we're inviting feedback on creating additional exceptions to the Two-Midnight Rule. We look forward to reviewing stakeholders' suggestions on these two subjects. Mr. Chairman, Ranking Member, I look forward to hearing this subcommittee's ideas regarding the Two-Midnight Rule and the Recovery Audit Program. CMS is always looking to improve our policies and procedures, so we welcome this opportunity to hear from Congress and stakeholders. With that, I'd be happy to take questions.
Thank you. Ms. Noodleman, you're recognized for 5 minutes.
Good morning, Chairman Brady, Ranking Member McDermott, and other distinguished members of the subcommittee. Thank you for the opportunity to discuss the Office of Inspector General's work to improve the Medicare program. My testimony today has 3 key takeaways. 1, the Two-Midnight Hospital policy must be carefully evaluated. 2, CMS should enhance its oversight of the recovery audit contractors. And 3, fundamental changes are needed in the Medicare appeals system. I will begin with the Two-Midnight Rule. The new policy provides guidelines for when hospitals bill for inpatient stays and outpatient services, such as observation. These decisions have significant impact. They affect how much Medicare pays the hospital, how much beneficiaries must pay, and beneficiaries' eligibility for skilled nursing facility services. Prior to the policy, OIG evaluated hospitals' use of observation stays and inpatient stays. Our findings continue to be relevant. We found that beneficiaries were in observation and short inpatient stays for similar reasons, but short inpatient stays were more costly. On average, Medicare paid nearly 3 times more for short inpatient stays than observation stays. Beneficiaries paid almost 2 times more. We also found that hospitals varied. Some hospitals used short inpatient stays for less than 10% of their stays. Others used them for more than 70%. Lastly, we found that some beneficiaries spent 3 nights or more in the hospital, but did not qualify for the skilled nursing facilities under Medicare. That is because their stays did not include 3 inpatient nights. Switching to our work on recovery audit contractors, or RACs, we found that these contractors play a critical role in protecting the fiscal integrity of Medicare. In fact, in fiscal years 2010 and 11, RACs identified improper payments totaling $1.3 billion. Most of the recovered improper payments came from hospital inpatient claims. However, we also found that CMS needs to enhance its oversight of RACs. Finally, OIG has found that the Medicare appeal system needs fundamental changes. We reviewed the third level of appeals, which is handled by administrative law judges, or ALJs. Although this work predated the recent surge in appeals, our findings and recommendations are relevant to the current challenges. We found that ALJs decided fully in favor of appellants in over half of the cases, and Part A hospital stays were most likely to receive favorable decisions. Several factors led to ALJs reaching different decisions than the prior level. One is that some Medicare policies are unclear. This leads to more favorable decisions for appellants and to more variation among adjudicators. In fact, there is wide variation among ALJs. Their rate of favorable decisions ranged from 18 to 85%. We also found that improvements were needed, such as ALJs moving to electronic files and CMS increasing its participation at hearings. In closing, clear payment policies, strong oversight, and an effective appeal system are critical for Medicare to work well. CMS policy, the RACs, and the appeal system must each fulfill their important purposes. If they do not, beneficiaries, taxpayers, and the Medicare program suffer. OIG is committed to continuing our efforts to improve Medicare. Thank you for your interest and for the opportunity to discuss some of our work. I'm happy to answer any questions.
Thank you, Ms. Noodleman. I think both witnesses have made the point that two-midnight policy, the inpatient, outpatient, the audits, and the appeals all really work together, which is why we're doing this hearing all together. So, starting Mr. Kavanaugh, I'm interested in hearing your thoughts on the barriers to compare inpatient, outpatient services. Obviously, we should be trying to find the best quality care at the right site with the most cost-effective payment. So, can you give me an example of reimbursement difference for a service that can be billed both inpatient and outpatient by a teaching hospital in a major city? What would be an example?
Well, Chairman, as you pointed out in your opening statement, the outpatient payment system and the inpatient payment system are fundamentally different, and they start with different coding. So it's often hard to compare payments because we can't put the same claim through the outpatient system and the inpatient system. They are coded differently. But on the inpatient system, we tend to pay a fixed amount, meaning a DRG-based payment. That DRG-based payment will include adjustments for possibly IME, for DISH. It could include a readmissions penalty or a hospital-acquired condition penalty. But it tends to be a fixed payment for the type of patient and the type of service being delivered. On the outpatient side, it's more disaggregated, where we tend to pay per service. I think you heard from the OIG, and I think it's similar to data we have, that the magnitude of the difference in payment is quite substantial. The OIG mentioned that the short stay inpatient payments tended to be 3 times as costly to Medicare as the outpatient observation stays. That's consistent with data we've seen at CMS. So that gives you a sense the systems for deriving the payment are different, and the magnitudes are quite different.
How do you address that?
I'm not entirely sure how we address it. One idea that we received from stakeholders, and I know that has some support in Congress, is to create a payment system that splits that difference, a short stay inpatient payment system. And as I mentioned in my opening statement, we are soliciting comments on how to create such a payment system. I would say there are challenges. Some of the cases that come in as short stay inpatient payments already have very low lengths of stay. Chest pain DRG, for example, has a 2-day average length of stay. So the question is, how would you create a short stay payment around a type of case that's already fairly short? Those are the sorts of technical questions that we're asking for public input in the proposed rule this year.
Thank you. Ms. Noodleman, you know, in your analysis, do you think the two-midnight standard will reduce observation stays or increase them, the length of them?
Yeah, again, our analysis is prior to the 2 midnight stay, and it is difficult to predict how things will look. What we did find is that hospitals extremely vary, and therefore it's important to look at all of the data because their starting point is very different, and so it may impact hospitals very differently.
Mr. Kavanaugh, you made thanks for your emphasis describing the different cost-sharing implications affecting our Medicare beneficiaries. That often gets lost in this discussion, and the difference between inpatient and outpatient. It's unfortunate the Medicare program has such vastly different cost-sharing rules for our seniors, our Medicare beneficiaries between the two benefits. So this committee is focused earlier on the advantages of combining Medicare Parts A and B with the out-of-pocket costs to make sure we protect seniors in part, because we're concerned about what seniors pay for cost sharing. So can you give us your thoughts on combining Parts A and B and how that might be helpful in trying to contain those cost-sharing challenges for seniors?
I recognize that one of the goals is to speak to one of the problems that we have here, which is that inpatient versus outpatient generates very different liabilities for the patient. I'd want to hear more about the proposal that the subcommittee is considering, and we have technical staff at CMS who can come provide assistance to you in the drafting of the bill if required, and if that would be beneficial to the
So you've not taken a look at the proposed combining Part A and B in the President's budget or in earlier health care proposals?
We don't have a proposal on that at this time, but like I said, if the committee has a proposal, we'd love to see it and learn more about it.
Okay. Final question. Mr. Kavanaugh, even though CMS doesn't have a direct role in the ALJ level Medicare appeals that Ms. Noodleman talked about, CMS must still be part of the solution to solve the backlog. Does HHS have a working group to address Medicare appeals? And if so, has HHS crafted recommendations to solve the backlog issues going forward?
Yes, Mr. Chairman, as you point out, there is an HHS-wide work group to address the backlog. CMS is part of that. I'd be glad. We are in the process of coming up with recommendations. I don't believe they're finalized yet.
What's the timetable on that?
I think we could brief the committee on them fairly shortly.
Great. Thank you, Mr. Kavanaugh and Ms. Noodleman. I now recognize Ranking Member Dr. McDermott for 5 minutes.
Thank you, Mr. Chairman. From a patient standpoint, you walk into the emergency room or whatever, and you get put in one of these statuses or the other. Does it make any difference to the patient, to the beneficiary, which status they're put in as to how they're treated?
As to how they're treated, not from a benefit perspective? Is that
Yes, I'm talking as how they're treated as a patient.
I would hope not. I would hope that the patient is receiving all the services they need medically, that are medically indicated.
So then the difference is in the payment that's received by the hospital or that the patient has to make depending on which category they're in. Is that correct?
Certainly the statute creates a stark difference between inpatient and outpatient care, yes, sir.
Give us the amount of difference for a hospital, what they receive and what the patient has to pay, so we get some idea of who's bearing the weight here.
These will be, the amounts both that the hospital will receive and that the beneficiary would be liable for would vary tremendously on individual circumstances. So I can't give you a precise answer. I would say that when we did a rebilling initiative where we had hospitals take short inpatient cases and rebill them as outpatient, which involves some work, we did find that the outpatient payment to the hospital was about 30% of what the inpatient payment would have been.
So they're getting 60%, 70% more if they bill them as an inpatient. Is that in Medicare payment for the DRG, the diagnosed related group, or is it the indirect medical education and the dish payment on top? What
It includes everything.
What's the split? Okay, so you're saying you're including everything.
Yes, sir.
So it's to the hospital's best interest to bring them in as an inpatient
Certainly, it generates more revenue.
from a revenue standpoint, not, because we said it doesn't make any difference how they're treated as people and as patients. So the only difference is how much money the hospital makes off of them. Is that correct?
Again, it certainly makes a significant financial difference.
Now, I've heard, and I think almost every member on this committee has probably heard from their hospitals. The usual assumption is that the RACs are overzealous, and that somehow when we take them up to appeal, when we finally get to the appeal process, almost always it comes down in our favor. Could you give us the numbers of how many are overturned on appeal?
Certainly, Congressman. We had a report to Congress on the RAC program in on the year of 2012, and in that report we showed that when a RAC denies a claim, only 7% of those are ultimately overturned at some level of review, all the way up through the ALJ.
Only 7% are overturned. Now, where do the hospitals get the figure that they say, oh, they're all overturned? When we finally go through this long, arduous process that's backlogged and everything else, it's always overturned. Where do they come up with that?
There could be two sources of the difference in these numbers. The first is any individual hospital's experience may vary tremendously. Some may have a better success rate. The other is some of the numbers that I've seen quoted by the industry, they're using as the denominator only those that they choose to appeal, not all those that were denied, which a lower denominator would generate a higher rate of success.
Does it get to more than a half?
In the numbers that we've seen that CMS has generated, I haven't seen anything that would get that high, no, sir.
The number I saw, I mean, you're holding back on the numbers you got. The ones that I've seen say 27% are the number that are overturned.
So again, I don't mean to hold back the numbers. These are numbers that are in a public report to Congress.
Yes, right.
Ultimately, and I'll just state it as clearly as I can, of all the ones the RACs deny, only 7% are ultimately overturned. If you took a low number of the ones the RACs denied and the hospitals chose to appeal, it would generate a higher overturn number. I just don't happen to know that number. 14%.
14%.
I'm being helped, yes. So it essentially doubles the rate, but it doesn't get as high as some of the numbers you may have heard from others. And again, an individual hospital's experience may vary.
Can you give us an explanation for why this problem? I mean, generally Congress doesn't run in and pass laws, and you don't make rules and regulations without there having been something to generate that. What is it that drove this in the first place?
I think it was a confluence of a number of factors. We were hearing from hospitals and beneficiaries who were really concerned about these long observation stays. That was causing confusion for beneficiaries, and including they didn't understand their status, and they also thought they were qualifying for the skilled nursing facility benefit. We were hearing from hospitals who thought just dealing with the RACs, with what the hospitals would characterize as an unclear standard for inpatient care, was a difficult situation to put them in. And all these forces came together, and that's why CMS solicited input and tried to make a clearer policy. Because our goal is not to have a successful RAC program or to drive down the number of overturned appeals. Our goal is to have hospitals understand the rules, agree with the rules, and bill correctly at the outset.
All time has expired. Mr. Johnson?
Thank you, Mr. Chairman. Mr. Kavanaugh, the value-based purchasing program, which was enacted as part of Obamacare, is the federal government's most extensive effort yet to hold hospitals financially accountable for patient outcomes. Medicare compared hospitals on how faithfully they followed basic standards of care and how patients rated their experiences. In the first year of CMS value-based purchasing program, physician-owned hospitals demonstrated they thrive in delivering high-quality, low-cost care. Amazingly, 9 of the top 10 and 53 of the top 100 hospitals were physician-owned hospitals. CMS also recently released data that summarizes the utilization and payments for procedures and services provided to Medicare. Based on this release of information, we have now confirmed what many of us have known for some time, and that is that physician-owned hospitals are costing Medicare less than hospitals without physician ownership. And that doesn't consider all the cost savings associated with the higher quality of care they provide. The irony of all this is that the very law that created the hospital value-based purchasing program, Obamacare, bans the same hospitals this new accountability measure says are some of the very best in the country. Obamacare prohibits any new physician-owned hospitals from treating Medicare and Medicaid patients. This clearly discriminates against some of the most vulnerable patients in our health system. While the law permitted those physician-owned hospitals that received Medicare certification to be grandfathered under the law, it prevents these same hospitals from being able to expand to meet the access and quality demands in their community. This makes no sense, and it flies in the face of the administration's own benchmarks for quality of care and cost savings. Mr. Kavanaugh, do you stand by the results of the value-based purchasing program, which validates the quality of physician-owned hospitals?
Yes, the agency stands by the results of the value-based purchasing program.
Do you stand by the data released by CMS showing the cost differential between treating patients at physician-owned hospitals versus hospitals without any ownership by physicians?
I apologize, Congressman. I'm not familiar with those data, but I'm happy to look at them and review them. And
appreciate it if you would. I hope you all can support a bill that I've got out there, which H.R. 2027, which would establish a level playing field for physician-owned hospitals and ensure that patients will continue to have a choice in where they receive their health care.
certainly, we look forward to reviewing that legislation.
Thank you, sir. Thank you, Mr. Chairman.
Thank you. Mr. Thompson is recognized.
Thank you, Mr. Chairman. Thank you for holding this hearing today. I think this is something, as Mr. McDermott said, we're all hearing a lot about in our district. Mr. Kavanaugh, I'd like to just revisit the issue of the reversed audits. And you had mentioned 7%. Mr. McDermott said that he hears from his constituents that every one of them are overturned. I'm hearing that it's in the 40% from my hospitals, 40% and change. And is there any way to qualify how these missed billing are done? Are they intentional? Are they mistakes? What is your experience?
Certainly my experience, which actually predates my time at CMS. As I mentioned in my opening statement, I've only been at the Director of Center for Medicare for a few weeks, but I do have experience working in the hospital industry. My experience has been most of them are not fraudulent. It's misinterpretation.
So they're honest mistakes, or they find the process is confusing, have trouble getting to where they need to be?
Certainly that's what I've heard from much of the industry. I would also say, by monitoring these very closely, the agency has at times found suggestions of fraud in some areas, but I don't think that's generally what's driving this.
And is it pretty easy to recognize the mistakes vis-a-vis the fraud?
I would have to defer that question to my colleague who runs the program integrity side of CMS, excuse me.
I'd like to know that if you could.
We'd be happy to circle back with you after the hearing.
But whichever it is, when a hospital has to go through the process of defending their claim, there's a lot of expense associated with that.
That's true.
Are you able to qualify that?
Well, we don't collect data on what the hospital's expense is, but certainly my experience.
They hire, what, lawyers?
At times, lawyers or
consultants, and
there's also just the time and the
all the
financial
opportunity
uncertainty.
Costs. They're defending their billing practices rather than providing health care to patients.
Yes, Congressman. Again, that's why we feel perfecting the appeal process is important, but what's more important is having very clear guidelines at the outset of how these cases should be billed.
And is there any way to minimize the cost to hospitals if their claim is reversed? They have to pay one way or the other, I guess, huh?
Yes, if it's reversed. There are some things that we are doing. The recovery auditor contracts are being recompeted as we speak, and we hope to award new contracts this summer. In that process, as we set new terms with the recovery auditors, we are trying to take some steps to make things less burdensome for the hospitals. We're trying to revise the requests the auditors do for documents from the hospitals to try to limit that burden somewhat. We're trying to ensure that there's an exchange of information between the auditors and the hospitals so the hospitals can make their case before they have to file a formal appeal, that they can work with the auditor to explain why they think it was appropriate in his inpatient case. So we're always looking for ways to improve this, and I think there is room.
Does the process incentivize the auditors to go after more than they should?
I don't think there's an incentive for them to go after more than they should, and I think the very low overturn rate that I quoted suggests that they're largely going after the right types of cases. But again, I would rather that they have...
That's the overturn rate that you quoted, the 7%.
Correct.
But if it's closer to what Mr. McDermott said, where they're all overturned, or even if they're what my hospitals are experiencing, about 40-some-odd%, it's not quite as low.
If I believed that of the claims
so
that
they say there's lies, there's damn lies, and there's statistics.
I just wanted to agree with you, though, that if there were overturn rates of 40, 50%, I think that would be indicative of a larger problem than just the guidelines.
What would that problem be?
I think it would indicate that the recovery auditors were not going after cases that were
Auditors are what?
That the recovery auditors, if they were getting overturned 40 or 50% of the time, it would indicate they were probably going after cases that were appropriately billed to start with. But again, that's not what we see in our data.
So, Mr. Chairman, can we further examine that? Because if that's the case, they are being incentivized, or for some reason they're going after cases they shouldn't.
At some point today, I'm going to recognize Mr. Roskin, but at some point today, I'd like Ms. Noodleman to weigh in. I want to reconcile the differences in the numbers. I may be missing something here, and at some point, I don't want to take Mr. Roskin's time. Mr. Roskin.
Thank you, Mr. Chairman. Mr. Kavanaugh, I just want to pick up on one of the themes that Mr. McDermott articulated in his opening statement, where he said that he wanted to protect Medicare's finite resources, and I agree with that, and you agree with that. One of the challenges, I think, is there is a zero-sum game element to Medicare reimbursement right now, and so I want to draw your attention to an issue that I'm sure is familiar with you. That's Nantucket Cottage Hospital. As you know, that was part of the process by which the Affordable Care Act was passed. I don't think any celebration in this, and that it is a zero-sum game proposition. I come from Illinois, and my home state is losing under this equation. Massachusetts, based on this manipulation, will essentially get $3.5 billion over 10 years. You recognize that that's a problem, don't you?
I'm familiar with the provision you're talking about, and I would just simply say CMS is faithfully executing the law as written.
You don't think that's a good allocation of resources, do you?
Again, I would just say that we're implementing the law as required.
Well, if it takes from my state and gives to another state, and what it does is it manipulates the definition of a rural hospital so that now Nantucket is now defined as rural, which boosts everybody up because you know these rules better than I do. The entire state of Massachusetts is the beneficiary of one hospital in a particularly luxurious area is now redefined as rural and therefore poor. That's a manipulation, isn't it?
Congressman, I think you've accurately described the mechanism of what is happening, and again, we're bound to implement the law.
But it's not a good idea, is it?
We're faithfully executing the law in this regard, sir.
Well, but I mean, if if you recognize that there's bipartisan support to repeal this, don't you? I mean, this is one of these areas where just a tremendous amount of bipartisan interest in trying to get back to this. Senators McCaskill and Coburn have come alongside with one another. There's dozens of members of the House of Representatives who've recognized this, and this is a situation where one state, based on one statute, is getting a disproportionate benefit, and it's not getting a disproportionate esoteric benefit. In other words, this isn't just simply, borrowing from a future generation. This is saying, we're going to take from Illinois and we're going to give to Massachusetts. That's a breakdown, isn't it? Isn't that a failure?
So, Congressman, the provision does involve some of the technical aspects of Medicare rate setting, and we have a lot of experts at CMS who we'd happy to bring down and provide you technical assistance if you have a legislative proposal in this request.
Well, is it a technicality when a luxurious vacation area is characterized as rural, thereby boosting every other hospital in the state and having an adverse impact on many other states? I mean, so Massachusetts, according to our staff that put this together in 2013 and 2014, is going to be receiving a benefit of $425 million. My home state of Illinois is down $62 million. Congressman Price's home state of Georgia is down $30 million. You know, you just go on and on through the list. Congressman McDermott's home state is down $12 million. This is beyond just a technicality, wouldn't you say?
What I was suggesting is that it's a function of very technical parts of the rate setting within Medicare, and we're happy to look further into it and look at your bill and provide.
But isn't that an overcharacterization to say it's just a technicality? I mean, it's not just technically taking millions of dollars from my home state and these other states across the country to benefit one state through the boosting of this sort of hospital definition. And if that's a technicality, then I shudder to think, what's a big deal? It's more than a technicality. Wouldn't you acknowledge that?
I didn't mean to suggest it was a technicality. What I was trying to say is that it was a function of technical aspects of the rate setting system. As you said, the provision has a meaningful impact on Medicare rates.
And wouldn't you technically think it's a bad idea?
Congressman, we're faithfully executing the law. If you have a provision to change it, we're happy to provide any technical assistance you might need.
Thank you. I yield back.
Thank you, Mr. Pascrell.
Thanks, Mr. Chairman. I think we can work together, I really do, to find solutions that work for hospitals and for patients. I've been hearing from hospitals in my state, Mr. Kavanaugh, about the various reporting requirements and programs that impact the work that those hospitals do. I don't think anyone here will disagree that there's much room for improvement in the RAC program and policies related to short-term as well as observation stays. However, we need to strike the right balance between ensuring that hospitals can comply and that Medicare has the ability to ensure program integrity. It sounds easy, but it's not. One area of particular interest to me is the increased use of observation stays and how it impacts the beneficiary. So I co-sponsored, along with Joe Courtney and Tom Latham, it's bipartisan, the Improving Access to Medicare Coverage Act, which would allow observation stays to be counted toward the 3-day mandatory inpatient stay for Medicare coverage of skilled nursing facility services. So here's my question then, Mr. Kavanaugh. A number of independent reports from MedPAC, the HHS Inspector General, Brown University, very interesting study, indicated that there's been a substantial increase in the number of observation stay claims and a decrease in the number of inpatient stays. According to MedPAC, outpatient observation claims grew by 88% from 2006 to 2012. A Brown University study found that the average length of stay in observation increased by more than 7%. Could you tell me what's contributing to this trend in the rise in observation stays?
Certainly, CMS is aware of the growth in observation stays as well. One of the things we believe is contributing to it is the behavior of some hospitals that want to avoid auditors reviewing whether an inpatient stay was appropriate.
You want to lay that on the record, please?
Excuse me?
What do you mean? What are the hospitals doing?
And again, this is anecdotal, having talked to some hospital associations and some individual hospitals, that some hospitals have decided they'd rather take the patient in observation status as excessive caution rather than risk having an inpatient admission subsequently denied.
And what does that lead to?
Well, first of all, what I think is unfortunate is, as you point out, if the patient should have been receiving inpatient care, they're not accruing the days they need to qualify for the post-acute skilled nursing facility benefit.
Yeah, that's pretty troubling. Under the current law, under what exists right now, Medicare requires that a patient be classified as an inpatient during a hospital stay for 3 days in order to qualify for coverage in a skilled nursing facility after they leave the hospital. So a number of Medicare beneficiaries have been cared for in the hospital on outpatient observation status rather than admitting them as inpatients, which has caused problems for Medicare coverage. That's serious. Mr. Kavanaugh, do you believe that the 3-day inpatient stay requirement for Medicare coverage of skilled nursing facility services is appropriate?
Congressman, I think CMS shares your interest in trying to find ways to improve the use of the skilled nursing facility benefit. I'm pleased to tell you there's 2 examples of where we're exploring very specific alternatives to this. In the Affordable Care Act, the Secretary and CMS were given the authority to waive certain provisions of Medicare in order to test new payment and service delivery models. In the Pioneer ACOs, which is run by the Innovation Center, and the bundled payments for care improvement, also run by the Innovation Center, we're running tests where participants in those models have waivers from the 3-day prior hospitalization rule. We chose those environments in which to test this because we feel in those environments the providers have both a clinical and a financial heightened clinical and financial responsibility, so we feel it's the best possible environment to waive the rule without having excess utilization. Those tests are fairly new, and we're going to evaluate them very closely, and when we have data to share, we'd be happy to share them with this committee.
Thank you. Thank you, Mr. Chairman.
Thank you. Mr. Gerlach, recognized. We'll move to 2-to-1 questioning so we can balance questioning from now on.
Thank you, Mr. Chairman. Thank you for testifying this morning, the both of you. On this 2-midnight rule issue, and staying with the questions that my predecessors here have just posed, I think a lot of this can be boiled down to some of the information we get from our subcommittee staff that summarizes the issues for the hearing today. And let me read, if I can, from that, because, again, I think it crystallizes on the 2-midnight rule where we are. And I quote, "For fiscal year 2014, CMS maintains 751 diagnostic-related group bundling codes for inpatient hospital payment. The outpatient payment system is focused on current procedural terminology, or CPT codes, that are maintained by the American Medical Association. The CPT codes map to ambulatory payment classifications, or APCs, for outpatient service reimbursement. For calendar year 2014, CMS maintains 813 APCs. There is no one-to-one matching of DRGs to APCs, nor international classification of disease codes to CPT codes. Hospitals are responsible for knowing 2 different coding systems and 2 different payment systems for Medicare reimbursement. Seems to me that's the problem, isn't it? A patient comes into a hospital, presents with certain symptoms and certain complaints, But there's two different coding systems that a hospital is then required to utilize in terms of the reimbursement it will ultimately receive for whatever service is provided to the patient. So does not the answer lie, obviously, to a new methodology that somehow blends these codes or smooths these two different payment systems, one outpatient, one inpatient, so there's a fair way to reimburse for the service provided, not the length of stay on an arbitrary basis? Mr. Kavanaugh?
Thank you for that question, Congressman. I do think in this year's rule, in which we requested input on a short stay inpatient payment system, we were suggesting that we're open to the kind of thing you're talking about, which is trying to see if a solution here is to minimize the payment differences. I don't want to prejudge the result of that. We are waiting to receive public comment on how that might look. But I think it's a openness to a step in the direction you're discussing.
Is that openness towards getting to a system where, again, the reimbursement to the hospital is based upon a more simplified methodology, and a methodology that's tied to the nature of the service that's provided, not an arbitrary time period for which that patient is in the hospital? And I'd also, Ms. Noodleman, if you'd also reply to that as well.
I defer to CMS and to Congress to make the policy, but I think the overall objective is going back to, not paying vastly different amounts for beneficiaries that receive similar care. At the very least, a standardized crosswalk that crosswalks the outpatient and the inpatient procedures would be a useful tool.
Well, typically, an inpatient reimbursement would be about 3 times what an outpatient reimbursement would be. So there would be a fundamentally unfair situation where somebody is discharged from the hospital at 10 p.m. before the second midnight, and therefore the hospital receives a third of the reimbursement for the services that were otherwise provided or could have been provided if you just kept the person 3 more hours and discharged him or her at 1 a.m. after the 2 midnights had passed by, and get 3 times the reimbursement. So isn't there a fundamental flaw in just arbitrarily setting up a 2 midnight or any particular time period for determining reimbursement versus just the nature of the service that's needed to treat the patient? As Mr. Kavanaugh, you alluded to some moments ago, that's the goal here, getting the patient properly cared for in the hospital setting based upon the symptoms and problems, and then the diagnosis that's made to deal with that.
I think, Congressman, it's fair to say CMS shares your goal. What I would caution you is anytime we create a new payment, there's a lot that goes into creating payment systems. And while what you're articulating, I think, is a very worthy goal of a seamless payment system, it presents many technical challenges. However, again, we've expressed openness in our proposed rule to exploring payment solutions to this. So we look forward to hearing any ideas this subcommittee has, and we look forward to working with you on this.
Thank you both.
Thank you, Mr. Smith. Thank you, Mr. Chairman, and thank you to our panelists here today. It would seem the more regulations we have, the more difficult it becomes. At least medical providers tell me that it's more difficult to do their job, and especially it becomes more difficult to do the right thing. And Mr. Kavanaugh, similar to concerns raised about the 2 midnight rule, there's another regulation. CMS announced it will begin enforcing this year pertaining to the 96-hour rule at critical access hospitals. This regulation requires, as you know, physicians to certify at the time of admission they do not believe a patient will be there more than 96 hours or must transfer the patient or face non-reimbursement. I understand CMS has walked back this rule, allowing more time to file this certification. Is that true?
That's true. We've provided guidance to some of the hospitals that we will allow the certification to occur anytime up to 24 hours before the bill is submitted, and I think that will be coming out more formally sometime soon.
Okay. I assume that you have received a good bit of feedback, as have I, from hospitals and physicians. Can you reflect a little bit, briefly, if you might, on the kind of feedback you received that would have prompted walking the rule back a bit?
Certainly, we got a lot of input about the timing and the burden and whether the trade-off between what we were seeking and what the hospitals were requesting, whether there was any loss in the assurances we needed that the patient was seeing the appropriate level of professional. And I think the hospitals made a convincing case that there was room for some adjustment in the policy.
It would seem that the rule is unnecessary and even arbitrary. How did you arrive at the actual number of 96 hours?
Sir, that part is in statute. The statute requires that the physician make a certification that the expectation when the patient arrived was that they would need no more than 96 hours.
What is the background on that 96 number?
I apologize, I don't know the story there. I just know it's statutory based.
And I mean, CMS has not enforced it up until, I mean, they've finally decided to start enforcing that. Is that accurate? They have not been previously?
Again, I apologize. I've been in the job for just a couple of weeks. I do know that the requirement does trace back to the statute.
Okay. I've introduced a bill, H.R. 3993, the Critical Access Hospital Relief Act of 2014, which would repeal the regulation, and I would certainly encourage the agency's support of that. I think it might even make a lot of folks' jobs more easy to carry out. And I know that we've got other burdens on critical access hospitals, such as the physician supervision, again, arbitrary, hard to determine how that ever even came about in terms of a rule or regulation. And it's very discouraging, I think, for medical providers to be facing all of these regulations that, like I said earlier, make it difficult for the good actor to do the right thing. I know we've seen advertising on television about addressing fraud in Medicare, Medicaid, and other areas, and yet I still think that all of these regulations are making it more difficult for the provider to do the right thing. I'm not convinced that it's actually preventing fraud. I can appreciate the fact that there are limited resources, that you acknowledge that, and that we are all trying to operate in a world of limited resources, and yet I think that many of these regulations are accomplishing the exact opposite of what they were intending to accomplish. And it's a huge burden, and I would hope that the agency would really reflect on that fact as we do move forward. Thank you, Mr. Chairman.
Thank you, Mr. Kind.
Thank you, Mr. Chairman. Thank you for holding this hearing. I want to thank our panelists for your testimony here today. Just to maintain the momentum of some of my colleagues, especially my friend from Pennsylvania, as I've been talking to a lot of our providers back home in Wisconsin over the 2 midnight rule, their sense is that it's awfully arbitrary, and they're having some definitional problems too, as far as what constitutes inpatient care versus observational status, outpatient care. Has CMS, Mr. Cavanaugh, been working with the provider community to provide better definition or clarity in regards to those type of services? And what is the difference? I mean, if they're in there under an observational status versus inpatient care, is there things you can point to that clearly distinguishes between the two types?
So first, on the first half of your question about whether we're working with providers, I would say we certainly are. I think it was a big part of our attitude going into this year. As you recall, we suspended the recovery auditors looking at these cases for these purposes because we wanted to work with providers, and we wanted to do it. So we have, as I said, the MACs going into each hospital and taking a small sample of cases and seeing whether they're complying with the rule. And in instances where hospitals are, they're left alone for the rest of this year. In instances where hospitals are having trouble understanding or implementing the new rule, the MACs are working with them to educate them. So I do feel like we've taken this pause in the recovery audit program looking at these types of cases for the very reason you say, which is to work with the hospitals. And again, the origin of the rule was to respond to the request from the industry for clarity. One of the things we may be learning is that additional clarity is needed, or as we discussed, perhaps additional payment solutions are needed. We'll wait to see how these discussions go. But I do think you raise an important point, that this is a dialogue between us and the industry, and we do hope to learn quite a bit during this time.
Well, are there clear distinctions that can be made between inpatient, outpatient status, or observational status within the hospital setting?
Certainly, observation status is supposed to be used for a short period for the purposes of determining whether a patient needs inpatient level of care, and during that time, there ought to be diagnostic and other monitoring being conducted. I would hesitate to go any further into the distinctions because I am not a clinician, but I think your point is well taken, which oftentimes these are based on complex medical judgments that are difficult to translate into payment policy.
You know, you mentioned that CMS is moving forward on a short stay payment rule right now, and you're starting to get some feedback, some comments on that. What are the various factors, just for the committee's benefit, what are the various factors that you're taking under consideration in putting that rule together?
Well, the two questions we posed specifically in the proposed rule were, one, how would you define short stay cases? And there are examples of this. There are other payment systems out there that do use short stay payments, so it's not unprecedented. But it is a bit challenging here, as I mentioned earlier, in that some of the cases that are inpatient that are subject to RAC review are often already very short stay, even when they're legitimately inpatient, meaning they have an average length of stay of 2 days. So how do you, if cases are typically 1, 2, or 3 days already, how do you carve out a short stay? And the second, and this has been the subject of several questions, the second question we posed to the public was, how would you construct this new payment? I think questions have arisen, would it include the IME and DISH adjustments, and things like that. And I think these are real important issues where we need some public feedback before we move forward.
Is uncompensated care or underinsured individuals, is that going to be a factor too in the short stay rule?
Well, the way that currently gets into Medicare payment is typically through the DISH adjustment, and I think that's a fair question of whether it should be part of this as well.
Let me take you in a different direction. Obviously, recently, CMS did their physician reimbursement data dump that received a lot of attention, a lot of articles, a lot of focus, especially on some reimbursements that seemed outside the norm or the parameters in that. We hear from the doctors in the follow-up questions that it wasn't just them. There were multiple docs or whatever using the same code in order to submit the billing information. Does that sound plausible to you, that is in fact what is taking place, and why some doctors are being reimbursed $12 or $14 million in a single year?
It is true that in certain instances, multiple providers can bill under the same identification number.
Why are we allowing that?
I think I'll have to look into that and get back to you, but I think there are legitimate
I'd like to follow up. It just seems if we're trying to bring greater transparency, allowing multiple providers to use the same code seems to work against that issue. It's something that I think we're going to have to address.
I'm happy to look into that.
Thank you, Dr. Price.
Thank you, Mr. Chairman. I want to thank the panelists as well. I think this is an incredibly important topic, and as a physician for over 20 years, know that we oftentimes don't put the patient at the center of these discussions, and it's sometimes hard to do, especially when we're talking about money. But, Mr. Kavanaugh, I was struck by the difference in the numbers that we hear recounted on the number of appeals that are either overturned or not, and your number of 7% astounds me because it's one that I've never heard before. So I suspect that includes all RAC audits that are done throughout the entire country. I don't want the answer to that, but right now I'd like it in writing later. But I think the question that we really need to ask is, of those cases that hospitals have appealed, that are inpatient stays denied due to medical necessity, what % of those are overturned at the QIC level and then at the ALJ level? Do you have those numbers?
I don't believe I have them handy, but we can get them, and we will get them to you soon.
I would appreciate that, and there's a hospital system in my area where 72% are overturned. 72%. So I would urge you to look at your testimony, which says when you're over 40% or thereabouts, something's wrong. Something's wrong with the system. I want to revisit that in a minute, but I want to touch on the 2 midnight rule. When a patient presents to the emergency room and is being admitted, when is there a physician that has to sign that says that this admission is medically necessary?
That says the admission is medically necessary?
And would qualify for the inpatient for the 2 midnight.
Well, the physician can give the order, or other qualified professional can give the order verbally, but has to countersign it at some point. It doesn't.
But the order has to be given at the time of the admission.
Yes. For a patient to become officially an inpatient, a physician or other qualified personnel has to give an order.
So we're asking our doctors to predict what's going to happen to that patient over the next 2 midnights. Is that right?
It is based on the physician. The 2-midnight rule is based on the physician's expectation. Physician's expectation based on what they know at that time. And if the physician's expectation isn't fulfilled, meaning if the patient recovers or something else intervenes, the rule is not what happened, but what the physician reasonably expected.
Wouldn't we just be better off if we said that doctors and patients and families ought to be making these decisions and not CMS?
Well, again, CMS we're trying to leave it largely to doctor's discretion, but we're also, as I said in my opening statement, we're trying to balance many goals here.
No, I got you. But many physicians out there will tell you that they don't feel that you're trying to allow them to practice medicine. Are there clinical studies or reports that back up the 2-midnight rule?
I'm not sure I understand the question, sir.
Are there any clinical studies, scientists that have done studies that say, yeah, this 2-midnight rule makes sense from the patient's perspective and being treated?
Well, again, we crafted
Are there any clinical studies?
The 2-midnight rule is relatively new. I'm not aware of any studies of it at this point.
If you are, I'd love to hear about it because I'm not aware of any either. CMS contracts with these recovery audit groups to go get that money, right?
CMS contracts with recovery auditors to review improper payment.
And you pay them a percent.
A contingency fee, yes, that's correct.
And when an appeal is overturned, do you go get that money back?
Yes, we do.
From the RAC? How much is that?
I'm sorry?
How much money is that?
In total or in any individual
Total.
case? I would be happy to go back and find that number. I don't know it all.
Good. Okay. Can different RACs have different criteria for what's medically necessary?
They're all supposed to tie to Medicare policy.
And what is the clinical input that RACs are required to have to define what is medically necessary?
If you mean, the RACs are required to have a medical director who's supervising all their medical policies.
And do medical specialty societies have an opportunity to review all of that?
Of the work of the RACs?
Yes.
Not directly, sir.
All of this money that's used to comply with all of these rules and regulations costs money, doesn't it? The hospitals cost money.
Yes, sir.
Millions of dollars, maybe more. Where's that money come from?
Well, Congressman, I think you're getting at a point that I would concede right away, which is our goal is not to have a lot of these cases reviewed, not to have a lot of cases overturned. Our goal is to have clear policies that hospitals agree with and can comply with.
Comes from patient care, though, right? Doesn't it? I mean, if the hospital has to put that money into complying with the rules from CMS that get more and more laborious, then that money's not going into caring for that patient. So when we hear one of our colleagues here say, if this really isn't affecting the patient, that's really not true, is it?
It is not a productive use of money, and it's why we're trying to reduce the need for this type of review.
Thank you very much.
Thank you, Mr. Renacci.
Thank you, Mr. Chairman. I want to thank the panel. Mr. Kavanaugh, Mr. McDermott asked you a question talked a little bit about 3 people entering the hospital, and I just was interested in your response. You said, I would hope that the patient receives all the benefits they are entitled to. I want you to keep that in mind when we go through a couple questions I have for you. You know, due to the increase in the length of observation days, more and more Medicare beneficiaries are losing out on skilled nursing coverage. The OIG found beneficiaries had over 600,000 hospital stays that lasted 3 nights or more, but did not qualify them for SNF services, skilled nursing facility services. I've spent the majority of my career, almost 25 years, in long-term care, in the long-term care industry. I've recognized the barrier to access that the current 3-day inpatient requirement has created for our seniors. For this reason, I've actually introduced legislation, H.R. 3531, the CARES Act, that not only removes this barrier, but also encourages hospitals and nursing facilities to communicate with each other before discharge. Mr. Kavanaugh, the seniors in my district are often unaware of the 3-day inpatient requirement. Furthermore, seniors and their caregivers are unaware of whether or not their hospital stays was billed as inpatient or observation. So I want you to think about that patient that enters the hospital, and they're entitled to long-term care under Medicare, and they end up in this quagmire of in an observation day, not an inpatient day, and quite frankly, they probably could go directly to a nursing home in many cases because the doctor is only sending them to the hospital because it's a requirement, and it's actually costing the Medicare system dollars to send them through to that hospital just to get them the path to that nursing home. So if you think about that patient, and again, going back to your comment, I would hope the patient receives all the benefits they are entitled to. We send this patient into a hospital because it's a requirement. They go through 3 days. They have to, to get to the nursing home. The doctor already says they belong in the nursing home. Again, I was in the industry for 25 years. I can tell you, these patients belong in that nursing home. And they get caught up in this observation day. But here's the problem. Then they're sent to the nursing home. And when they're sent to the nursing home, for 2,000 of the hospital stays, Medicare did not pay for NSF services, and the beneficiary was charged an average of $11,000. So now we have this patient who started in the hospital, ended up in an observation day, probably should have never went in the hospital if we had a different system that actually my bill would allow, that lets them go directly into the nursing home because the doctor says that's the care that's needed. So has CMS implemented any policies that would really decrease the instances in which seniors, and again, that's what I'm talking about, that person you talked about, the benefits that they're entitled to, where there were seniors who were caught off guard and left on the hook for thousands of dollars in medical bills?
Congressman, I think you raise a very important issue, and one that was one of the driving factors to us looking at the two-midnight rule. I'll tell you two things. One of the impacts we're seeing, at least preliminarily, of the effect of the two-midnight rule is we are seeing a decrease in these long observation stays. And I believe those are probably shifting to inpatient status, so potentially helping the beneficiaries you're talking about. But you're also talking about a larger issue of whether these patients need to go through the hospital in order to, or should need to go through the hospital in order to access the skilled nursing facility benefit. And as I mentioned to an earlier question, we're interested in exploring alternatives to that too. We currently have the Pioneer, a subset of the Pioneer ACOs, several of whom have had the 3-day prior hospitalization rule waived, so they can test whether there are safe and effective ways for patients to be admitted to the SNF without the prior hospitalization. And we are this year also allowing some of the participants, both hospitals and post-acute care providers, to do that as well in our bundled payment initiative. So we're hoping we'll gain clinical and financial evaluation results from that we can share with this committee and maybe apply to broader Medicare policy.
You would then agree, and it sounds like these studies will give us some of those answers, but you would agree sending somebody to the hospital and having the cost, the burden of that person in that hospital when they really could go to a nursing home might be a way of saving some dollars if we sent them directly to the nursing home.
We do feel there's potential there, but again, we're testing it, and I don't want to prejudge the results of these tests.
All right, thank you. I yield back.
Thank you. Mr. Crowley?
Thank you, Mr. Chairman. Thank you, Chairman Brady and Ranking Member McDermott, for allowing me to join with you all at this hearing today. And welcome, Mr. Kavanaugh. Good to have you here. And I know I speak for all my colleagues when I say we look forward to working with you in your new capacity, new role at CMS. So, and I represent parts of New York City, Queens, and the Bronx. I know you're familiar with those areas quite well. We're fortunate to have a number of highly regarded hospitals and medical institutions, many of which are also academic medical centers. And I know you're familiar with all those as well. These hospitals and others across the country are struggling with the implementation of the two-midnight rule. And while I appreciate CMS efforts to try and clarify when a patient should be admitted as an inpatient, I have serious concerns about the overall policy. Our New York hospitals focus primarily on providing the best medical treatment with great efficiency rather than on what time a patient is admitted. The two-midnight policy sets an arbitrary standard that does not always reflect the clinical judgment of the treating physician. Several months ago, Representative Gerlach and I introduced legislation to delay the enforcement of the two-midnight policy. I'm glad that this delay was included in the most recent doctor's payment fix, and I thank the committee for all of its work in achieving that delay. But the problems with the underlying rule remain, and they need to be addressed. That's why our bill also urges CMS to implement a new payment methodology for short inpatient stays that don't fit neatly into the divides of the two-midnight policy. I was very pleased to see that CMS's proposed Medicare inpatient rule for next fiscal year includes a request for feedback on establishing a short-stay inpatient methodology, which could help both providers and beneficiaries. I hope that CMS will continue to work closely with hospitals and patients in establishing this process and in taking into account the costs associated with operating, teaching, and safety net hospitals. It's important a new payment system protect graduate medical education and disproportionate share hospital payments. Now, I know the rulemaking process is underway, but can you comment at all on how you see this issue being addressed as you move forward, if there are any possible methods you have considered and are willing to consider?
Thank you, Congressman, and thank you for your kind words. I do know New York and the hospital industry there quite well, having worked there and in one hospital and closely with many of the others. You're correct. First of all, you're correct that Congress extended, and based on your legislation, the pause in the RAC review of medical necessity of inpatient stays until March of next year. I think that does give us all, both Congress and the administration, some time to think about how the policy is working and whether there are additional steps that are needed to make a clear payment policy that we can all agree on. One of those areas where we're going to spend a significant amount of time and resources on is exploring the possibility of a short stay outlier. I don't want to prejudge how we would do this because we are soliciting public input. But as I've said in response to several other questions, it is an intriguing idea, but it also poses, real conceptual challenges. We are up to those challenges, but I don't want to underestimate them. One of the things I would point out is if it is going to be an inpatient short stay thing, we are still going to need a definition of when inpatient care is necessary, because you will still have a distinction between inpatient and outpatient. We're going to have the challenge of how do you create short stay payment when certain DRGs are already very short stay. But I know, as I said, there's some very great minds up in the New York hospital industry that I know are working on this, and they've been in touch with us. We've been in touch with the other associations, so we eagerly await their input.
Thank you, Mr. Kavanaugh. I look forward to continuing to work with you in your new capacity, and hope that you have that same open mind approach when you're dealing with the committee and the chairman and the ranking member as well. So thank you for being here today.
Thank you, sir.
Thanks. Ms. Black?
Thank you, Mr. Chairman. I want to thank you for allowing a non-committee member to be here to listen to the testimony and have an opportunity to be able to ask a question. Ms. Nuttleman, I want to go to you. In your written testimony, you talk about some hospitals use the short stay inpatient for less than 10%, excuse me, of their stays, and others use it over 70%. Did you find any trends when you were looking at these vast differences between how hospitals use these and whether there's any type of hospital in particular that uses them differently?
Thank you for your question. As you know, we did see a lot of variation, but we did not look at whether there's certain types of hospitals that are more likely to use short inpatient stays. If the trend continues under the new policy, this is a really important question to look into further.
I certainly think that that's one that would give us a lot of information, because if you're using it for certain types of hospitals, is it cardiac hospitals? Is it where they're looking at orthopedic? I think it would be very interesting to take a look at the wide variance that's there between 10 and 70%. Let me go to another area that seems to be a lot of variance, and that is in your testimony on page number 5, underneath of the appeals. You note that about 72% of those who appeal are successful. And yet we keep on hearing this number of 7%. There's a real disparity there. Can you break that down? There's something else there that we're not exactly understanding.
Sure, let me try to do that. I think what we're seeing is there's about most of the appeals from RACs are not appealed. Most of the RAC decisions are not appealed. So according to our statistics, about 6% of the RAC decisions are appealed. Now, once those reach higher levels, about half of those are overturned. So that maybe can help reconcile some of those issues. Where the 72% comes into play is when we looked at the third level of appeals, the ALJ level. they overturn about 72% of hospital claims. So that would include both RACs, that would include other issues than just the inpatient.
So just to be clear,
Sure.
about 7%, 6 or 7%, depending upon who's talking about that number, but somewhere in that range, of those decisions that are made by RACs are appealed, and of those that are appealed, in this case of Part A hospitals, 72% of those prevail, correct?
Or overturn.
Of the
at
overturn. Of those.
ALJ level. Yeah,
ALJ
there's
level. Okay, well, that makes a
different
lot more sense
statistics at
because
different times, but-
there's a lot of disparity between 6% and 70%, and so that helps me to understand a little bit better about where those numbers are coming from. Thank you very much. Thank you, Mr. Chairman.
Thank you, Ms. Black. I'm now confused about the appeal process. I don't mean to intervene here for a minute before I go to Ms. Jenkins, but so 94% of the claims identified as overpayments aren't appealed. 6% left, almost half were decided in favor of the appeal. Is that right? So the overpayments, 97% of them, at the end of the day, are considered accurate.
Just repeat that last part of their sentence. I just didn't hear that.
Of the RAC decisions on claims identified as overpayments, 94% aren't appealed. Of the 6% that are left, half are overturned. So
That is according
you're
to
saying
our numbers.
97% of those overpayments are upheld.
Yes.
Half is 6, 3,
Yes.
94.
Yeah, and that is prior to the surge, and that's in fiscal years 2010 and 2011.
Okay.
So that could also be part of the issue.
Is there a dollar figure attached to that? For example, you may not appeal a $10 overpayment, but you would a $10,000 one. Does your analysis show of those that were appealed a higher dollar value of those? Again, Ms. Black, I don't mean to jump, but you were leading down the right road. What do you know about that?
I don't have the dollar values in terms of what is appealed in terms of dollar amounts. Is that something?
Can you try to figure that out?
We can.
Give us a little more texture about
Absolutely.
what of that 6%, what do they look like? You know, and are there higher dollar values? And are they in a certain area? And then 72%, tell me about that.
That's of the hospitals, the Part A hospitals are 72%. So according to what I'm reading here, at the ALJ level, appellants were most likely to receive favorable decisions for Part A hospital appeals at 72%. And if I may, Mr. Chairman, just interject one other thing that I thought about that I keep hearing from these hospitals is the length of time it takes them to go from the original decision that's made by the RACs to the time that they reach the ALJ level. Can you give us an idea about how much time period there is in that typically?
Sure. I mean, particularly now with the postponement of assigning appeals, which the OMHA just put into place, and they're projecting just from what's publicly available that cases will not be assigned for at least 2 years. So that's pretty significant.
So there is a cost to the facility in that time period where they're trying to appeal it and the payments that have been taken back. So thank you very much.
Very much so, Ms. Black. Thank you. And Ms. Jenkins, you probably never thought we'd get to you. You're recognized for 5 minutes.
Well, Mr. Chairman, I just thank you for allowing me to join you at today's subcommittee hearing, and I appreciate this panel for being here. These issues affect hospitals all over the country, and I've heard countless stories from Kansas hospitals about the difficulties they face surrounding the Medicare program. Lawrence Memorial Hospital in Lawrence, Kansas has asked that I share their perspective on recovery audit contractors. The hospital currently has $4.7 million being withheld because of RAC audits. It has appealed nearly all RAC audits, and so far has demonstrated a 96% success rate in the appeals process. Lawrence Memorial has brought to my attention What is a valid concern that I'm hoping that you will take into consideration? The hospital's forced to disallow Medicare days and discharges that are currently held up in the RAC audit process because of the massive backlog at the ALJ level of appeal. And the hospital is concerned that these audits, which are likely to be resolved in their favor, will not be completed within the 3-year window during which it can reopen the cost report window and count towards the EHR meaningful use requirements. This is just one of countless hospitals in Kansas that is experiencing the immediate and ancillary effects of the current flawed system. As we continue to discuss a way forward on this topic, please take this problem into account. Secondly, I'd like to highlight a program with the 83 critical access hospitals in Kansas and others around the country and what they are experiencing. I received a letter from the Anderson County Hospital in Garnett, Kansas, and I would ask the chairman's consent to insert the letter into the record.
Without objection.
This letter details the hospital's problem with CMS's final OPPS rule for 2014 regarding outpatient therapeutic services at critical access hospitals and supports legislation that I've introduced to delay enforcement of the rule until the end of 2014. This rule, while well-intentioned, is creating a regulatory hardship in rural settings. The letter notes that CMS has disallowed physicians at a hospital-based rural health clinic from meeting the direct supervision requirements, which makes it very difficult for Anderson County Hospital to be reimbursed by Medicare for services rendered. The most troubling part of the letter is that the hospital notes that the physician supervision requirements have no impact on the quality of care, and that the hospital will administer the outpatient therapy even without the Medicare reimbursement. This is a telltale sign of a misguided rule that has missed the point. So, Mr. Kavanaugh, is it your opinion that requirements on physician supervision of outpatient therapy services at critical access hospital are feasible, and would CMS benefit from a delay in enforcement in order to revisit this rule?
First of all, thank you for telling us about the experience of these two hospitals. I don't have an opinion on the delay, but I'm interested in the issue, and I'm happy to look into it further outside of this hearing if you're willing to share that experience with me.
Okay, we will follow up with you and would like to work with you to give these folks some relief and better care for Kansans.
I'm more than happy to look further into it.
Okay, thank you, Mr. Chairman. I yield back.
Thank you, Ms. Jenkins. And before we dismiss the witnesses, Dr. McDermott and I would love to have both of you give us more perspective by letter of the 6% that are appealed for overpayments, the value of them relative to the other base of them, which are related to the two midnights rule. Any other insight you can give us on those? The numbers seem very low compared to what we've heard anecdotally, and we really would like to have more light shined on those areas. If you don't mind, we'll follow up with you by letter, but we'd love to have, I think the members would love to have that perspective.
We'd be happy to do that.
With that, thank you very much, both of you, for testifying. Let's line up our second panel. Thank you very much. I made the introductions earlier, so we will, for the sake of time, go right into testimony. Ms. Duchendorf, you're recognized for 5 minutes. And welcome to all the second panel.
Chairman Brady, Ranking Member McDermott, and distinguished members of the subcommittee, thank you so much for this opportunity to testify today and share the Johns Hopkins experience on these important issues affecting hospitals and the Medicare program. I'm Amy Deutschendorf. I'm a nurse. I'm responsible for assuring the appropriate utilization of clinical resources for our patients in the right care setting, and that includes care coordination and the readmissions reduction initiative. My remarks today focus on two major changes: the CMS definition of an inpatient, the 2-midnight rule, and also the agency's recovery audit contractor program, both of which are draining precious hospital resources which need to be redirected to quality patient care delivery. We know that the 2-midnight rule was spawned out of an attempt to limit lengthy observation stays and add clarity to the definition of an inpatient, but unfortunately the rule adds a new layer of complexity that not only does not meet that CMS objective, but has created confusion and stress for our providers and our patients, and has been operationally extremely difficult to implement. Our observation rate has increased by 33% as a result of the 2-midnight rule. It's taken away physician judgment in the determination of hospitalization as an inpatient, and has instead required our physicians to become soothsayers as they try to project whether or not a patient who presents to the emergency department with a myriad of symptoms and comorbidities and determine if they're going to require greater than a 2-midnight stay. More importantly, under the 2-midnight rule, we have patients who require the services that only a hospital can provide, sometimes in the intensive care setting, yet we are calling them outpatients in this new world. This concept belies any rationality and has created safety and quality of care concerns. Medicare patients are being billed differently than other patients in equivalent services, for equivalent services. They're subject to paying deductibles and copays associated with Part B benefits, which could be up to 20% of their hospitalization. They think they're coming in for hospital care, and their Part A benefit covers that. We've had patients who've actually left and refused important diagnostic studies and medications as a result of increased financial risk. The 2-midnight rule is especially devastating for academic and safety net hospitals. There's been a reduction in inpatient volumes as a result of the 2-midnight policy, which has redirected dollars for necessary hospital care to the outpatient system, causing a loss of payments for critical community programs, indirect medical education, general medical education, and disproportionate share payments at a time we need them the most. Since its inception, RAC has created enormous financial and administrative burden on hospitals as we struggle to respond to the plethora of medical record requests and to the denials and Mount appeal processes. RAC has targeted short stays. Again, the assumption that these stays are medically unnecessary. In truth, short hospital stays are good and reflect the efficient and appropriate management of care, some of which can be very intensive. Even though Hopkins has a rigorous compliance process for which we review every day of every single Medicare patient stay for medical necessity, RAC denied 50% of the medical records that were requested. We took 239 of these to discussion, and immediately 135, almost 60%, were overturned at discussion even before the first level of appeal. The rest of our 92% are in the appeal process. The RAC program is costing American Hospital millions of dollars in administrative burden to manage the RAC request, denials, and appeals processes, as well as the financial hit for revenue losses for care that was provided to patients. There are a lot of smart and committed legislators and policymakers who've put their heads around these issues to come up with solutions that are workable. Unfortunately, with each iteration and layer of new ideas come complexities and unintended consequences that seem to yield the opposite result. In the case of the 2-midnight rule, Congress and CMS should consider reverting to an earlier time, that before October 1st, 2013, and should reinstate the determination of inpatient hospitalization based on physician judgment, with one caveat: that patients who are hospitalized for greater than 2 midnights for medical necessity and medically necessary hospital services should be presumed to be inpatients. If we are thoughtful about RAC reform, the short stay problem goes away, and alternative short stay payment policies become unnecessary. Congress should consider the formation of a multi-stakeholder collaborative working group to develop a sound alternative to the current Medicare audit program. We appreciate Congressman Gerlach's and Congressman Crowley's leadership as the lead sponsors of H.R. 3698 and Chairman Brady. Thank you for your attention to this issue and holding a hearing on it. Having nearly half the members of this committee support this needed reform sends an important message to your hospitals and to CMS that this issue must be addressed. The Two-Midnight Rule and the RAC program are draining precious time, resources, and attention that need to be more effectively focused on patient care. Johns Hopkins and hospitals around the country stand ready to work with Congress and CMS to support these efforts. Thank you so much for allowing me to testify.
Thank you. Dr. Evans?
Chairman Brady, Ranking Member Dr. McDermott, members of the committee, thank you very much for this opportunity to testify before you today. I am Dr. Ellen Evans, lead physician with Health Data Insights, the Region D CMS Recovery Auditor. I am a proud graduate of the University of Texas Medical School, residency trained, board certified licensed family physician with a certificate of added qualifications in geriatric medicine. I joined HDI during the RAC demonstration program. At HDI, I oversee all of our medical and clinical recovery audit activities. The recovery audit program is not focused on fraudulent payments. We review claims to ensure compliance with Medicare practices and also identify underpayments that are returned to the providers. This program is a critical component of Medicare operations because over $30 billion are improperly paid by Medicare every year. Since the Recovery Audit Program was passed and implemented in a bipartisan fashion in 2006, over $8 billion improperly paid Medicare dollars have been recovered, as well as over $700 million in underpayments returned to providers. Recovery auditors identify the types of claims that are most at risk of improper payment by employing vast auditor experience and using federal publications such as HHS, OIG, GAO, and CERT reports. Every issue a recovery auditor seeks to review is submitted first to CMS for a rigorous evaluation and approval process. Issues that are approved are posted to the recovery auditor's provider portal in advance of any activity. CMS has limited the recovery audit medical record request to 2% of Medicare claims for any given provider. All medical reviews are conducted by licensed and experienced clinicians who undergo extensive screening and comprehensive training. When a provider disagrees with an audit finding, the provider can initiate a discussion period before formally appealing the denial. This is in addition to the usual CMS appeals process. Though the program has proven to be cost-effective, recent constraints have caused a significant decrease in recovery audit reviews. First, as part of the implementation of the Two-Midnight Rule, a moratorium was placed on recovery auditors, preventing auditing of short-stay hospitals for 18 months. Second, CMS announced the program would be suspended until new contracts are in place. The award date is currently unknown. These two changes will result in over $5 billion of improper payments not being restored to the Medicare Trust Fund. Now let me provide you some facts about the program. First, a recovery auditor is required to return all of its fee when a finding is reversed upon any level of provider appeal. This means recovery auditors are incentivized to work accurately and precisely. Second, according to the most recent CMS report to Congress, only 7% of all recovery audit determinations have been overturned on appeal. Third, recovery auditors are accurate. An independent CMS validation contractor gave recovery auditors a cumulative accuracy score of over 95%. Finally, recovery auditors target improperly paid claims of all types. Yet Medicare data have noted consistent high-dollar errors for inpatient short stays. Based on this data, it is imperative to the longevity of the Medicare Trust Fund to correct inpatient short stays. That being said, we understand the frustration expressed by the hospital community surrounding the Two-Midnight Rule. We want to work with CMS and the providers to bring clarity to the rules. As the committee moves forward on this important issue, I offer the following recommendations for the program. First, we support the ALJ appeal reforms outlined in the November 2012 HHS Office of the Inspector General report. Second, we support continued effort by CMS to offer providers front-end education to increase provider knowledge of Medicare policies. And lastly, we support increased dialogue among recovery auditors, providers, policymakers to improve the direction of the program. We are pleased to be a part of the dialogue today. The Recovery Audit Program must continue to play a role in the Medicare program, especially in light of the recent increases in improper payment rates. I appreciate the opportunity to appear before you all today and would be pleased to answer any questions that you may have.
Thank you. Dr. Sheehy?
Chairman Brady, Ranking Member McDermott, and members of the committee, thank you for the opportunity to testify today on observation status, the Two-Midnight Rule, and related issues. My name is Ann Sheehy, and I'm a physician at the University of Wisconsin Hospital in Madison, Wisconsin. I'm a hospitalist, which is a physician who cares for patients primarily in the acute care hospital setting. I'm also a member of the Public Policy Committee of the Society of Hospital Medicine, an association that represents the nation's more than 44,000 hospitalists. Observation care is often provided in the same hospital beds as inpatient care, and to a physician and a patient, the care provided is indistinguishable, but is considered outpatient, not covered by Medicare Part A. Many Medicare beneficiaries ask how they could be outpatients when they are staying overnight in a hospital. Many ask me to change them to inpatient, which is something I cannot do under current policy. The Centers for Medicare and Medicaid Services describes observation as a well-defined set of services that should last less than 24 hours and in only rare and exceptional cases span more than 48 hours. We published our University of Wisconsin hospital data in JAMA Internal Medicine last summer. The average observation length of stay at our hospital was 33 hours, and almost 1 in 6 of our observation patients lasted longer than 48 hours. We also had 1,141 distinct observation codes. We concluded that observation status for hospitalized patients was markedly different from the CMS definition I just stated, as mean length of stay was longer than 24 hours, observation stays beyond 48 hours were common, and the number of diagnosis codes showed that this was not well defined. These numbers demonstrate that observation care in real clinical practice is vastly different than how CMS intended observation to be. Any attempt to reform observation policy must recognize how far observation status has strayed from what observation should truly mean. And this problem is getting worse, with more beneficiaries disadvantaged by observation. The most recent MedPAC report documented a 28.5% increase in outpatient services from 2006 to 2012, with a 12.6% decrease in inpatient discharges over the same time period. As the committee is aware, CMS recently established a new policy to determine observation and inpatient status. As of October 1, patients staying less than 2 midnights, with some exceptions, were to be observation, and those 2 or more midnights would be inpatient, although full enforcement has been delayed through March 31st of 2015. The Two-Midnight Rule has presented new challenges in observation care. For example, a Medicare beneficiary may be hospitalized with pneumonia and is improved enough to leave the hospital after 40 hours of care. If that patient happens to get sick and present to our hospital Tuesday at 1 a.m., this means I would discharge them at 5 p.m. on Wednesday, a 1-midnight stay. But if the same patient becomes ill at 10 p.m. on Tuesday and needs the exact same 40 hours of care, I would discharge them at 2 p.m. on Thursday, a 2-midnight stay. Thus, the time a patient gets sick, not different clinical needs, may determine a patient's hospital status and insurance benefits. This is not just a theoretical finding. In a second JAMA Internal Medicine publication last year, we found that almost half of our University of Wisconsin hospital less than 2-midnight encounters would have been assigned observation status instead of inpatient by virtue of time of day of presentation. Clinically, the 2-midnight rule hurts a new population of patients, those staying less than 2 midnights. As an example, a patient with diabetic ketoacidosis may be sick enough to require intensive care unit admission and an extraordinary amount of services that can be life-saving, certainly a level of care that could not be delivered safely as an outpatient. Yet these patients can improve quickly, sometimes in 24 to 48 hours. Now a short stay, even in the intensive care unit, can be considered outpatient. The RAC program was well-intentioned, and Medicare fraud and abuse cannot be tolerated, yet we need more transparency and oversight of Medicare's current auditing programs. The reality is the RAC program costs all of us. In a recent one-year period at the University of Wisconsin Hospital from October of 2012 to September of 2013, we appealed 92% of RAC audits for medical necessity, and we have won every single appeal that has been decided as of May 14th of 2014, which is already 2/3 of these cases. Essentially, our hospital pays to prepare these cases in order to prove we were right the first time, but the RAC pays no penalty for generating this work. These are Medicare dollars that hospitals spend not on direct Medicare beneficiary care, but on a process of defending themselves against RAC auditors. In addition, the federal government ultimately pays for unchecked RAC activity in the appeals process, as evidenced by the current OMHA case backlog. The RAC system generates a large number of these payment denials at no consequence to the RACs, but at a direct cost to the federal government. To again consider the patient with diabetic ketoacidosis needing intensive care for less than 2 midnights, why would I not just claim inpatient status? Because this case is counter to the current observation rule of 2 midnights and is highly vulnerable to audit. This means an auditor who never met the patient in question a year or more after the patient discharges home may decide to question my judgment as a physician and audit. Provider autonomy and ability to do what is right can be trumped by the RAC system. In conclusion, observation status certainly merits reform, and the 2-midnight rule is not the answer. The 2-midnight rule and observation status in general negatively impact the delivery of good patient care. We need common sense solutions and that most importantly consider the original intent of observation policy. I would caution, however, that observation reform will not be successful unless there is concurrent reform of the federal auditing programs that enforce observation rules. The Society of Hospital Medicine looks forward to working with the committee on identifying workable solutions to problems associated with observation care and the 2-midnight rule.
Thank you. Ms. Edelman?
Mr. Chairman and members of the committee, my name is Toby Edelman. I am a senior policy attorney with the Washington, D.C. office of the Center for Medicare Advocacy. The center is a not-for-profit, nonpartisan, public interest law firm based in Connecticut that provides education, advocacy, and legal assistance to Medicare beneficiaries. We are very pleased to be invited to testify today about the impact on Medicare patients of outpatient status and observation status. 6 years ago, a woman called our office with a Medicare problem. She had spent some time in a skilled nursing facility, but the facility told her that Medicare Part A would not pay for her stay because she had not been an inpatient in an acute care hospital for 3 days. She asked how that could possibly be true. After all, she had been in the hospital for 13 days. It turned out that the hospital had called her an outpatient for all 13 days. The Wisconsin woman had no way of knowing she was an outpatient in observation status. She was in a bed in the hospital for 13 nights. She had diagnostic tests, received physician and nursing care, medications, treatment, food, a wristband. Her care was indistinguishable from the medically necessary care she would have received if she had been formally admitted as an inpatient. As in most hospitals, she was intermingled with inpatients, so even the physicians and nurses providing care to her didn't know whether she was an inpatient or an outpatient. And the hospital was not required by CMS rules to inform her that she was an outpatient or the consequences of that status. But solely because she was called an outpatient in observation status, Medicare Part A did not pay for her post-hospital care. Medicare limits payments to SNFs for hospital patients who are called inpatients for 3 consecutive days, not counting the day of discharge, what we call the 3-midnight rule. In the past 6 years, the center has spoken with literally hundreds of families from all over the country with similar experiences. It's a very rare day that goes by that we don't hear from at least one person, and usually more. I would like to describe a more recent case and the consequences. A 90-year-old man living at home with his wife had a fall. He went to the urgent care center, and the physician there advised him to immediately go to the hospital because of the hematoma on his leg was growing rapidly. The daughter who called me told me that as her father was being wheeled into the operating room, the hematoma burst. He had emergency surgery to evacuate the hematoma and remained in the hospital for 4 midnights, all outpatient. From the hospital, he went to the skilled nursing facility for rehabilitation, stayed for 18 days, and went home. If the man had been formally admitted to the hospital as an inpatient, Medicare Part A would have paid the entire bill for his 18-day stay. Medicare Part A payment is comprehensive and pays for room and board, nursing care, therapy, drugs, everything that the patient needs during that stay. Medicare pays 100% of the cost for the first 20 days in the SNF, and beginning on day 21, the resident pays a co-payment, up to a 100-day maximum number of days in the benefit period. But because her father had been called an outpatient during his entire 4-day stay, Medicare did not pay, Medicare Part A did not pay. The man had to pay out of pocket the SNF charges For room and board, the charges were $4,573 for the 18-day stay. In addition, he had to pay Medicare Part B co-payments for all of the therapy he received daily, and he had to pay for his prescription drugs. An administrative law judge found that the man's primary care physician supported an inpatient admission, and she also found that he had not been informed of his outpatient status. Nevertheless, she upheld denial of Part A payment for his SNF stay solely because he was, as she described him, hospitalized as an outpatient. Obviously, from the perspective of patients and their families, what is happening makes no sense. When patients need to be in the hospital for the diagnosis and treatment of acute care conditions, and when they're getting medically necessary care they need in the hospital for multiple days and nights, they do not understand why they're called outpatients and why their care in the SNF will not be covered. You've heard from physicians and hospitals this morning about why calling hospitalized patients outpatients is causing hardship for them. And some of the issues that we've been discussing this morning are very complex. But the solution for Medicare patients is simple and straightforward. H.R. 1179 counts all the time in the hospital for purposes of satisfying the 3-midnight rule. As of last week, there were 144 co-sponsors. There's a companion bill in the Senate, and the bills are bipartisan. The legislation is supported by a broad, ad hoc coalition of 30 organizations, and I've attached our common fact sheet to the end of my testimony with all of our logos on top. We urge the committee to quickly move on this legislation as you consider these other far more complicated issues. Thank you.
Thanks, Ms. Edelman. Thank you all for your testimony. Ms. Duchendorf and Dr. Sheehy, do you think, your view, do RACs disproportionately target high-value inpatient claims?
Yes.
Yes.
In the appeals of those, could you give us what you think is the true cost of an appeal? My assumption is high-value claims are more complex. There's more of the file to review. You're obviously bringing in medical professionals as well as the appeals process. In a case like that, for a hospital, what's the true cost of that appeal, roughly? I'm sure it varies, but...
So we actually, when RAC was proposed several years ago as a permanent part of the program, we actually went through a process to estimate the cost of an individual appeal. You have to add into that all of the costs associated with the medical record requests, the issues in terms of loading this into software because of the mountain, and for a hospital like Hopkins, it could be 600. And then you've got 50% of those that may be denied, so then the tracking and everything that goes along with that. So there is all of that prior work. Then there is the estimation of time it is for our nurses to review the cases, our physicians to review the cases.
What do you think that cost is overall?
So we estimated it was about $2,000 an appeal at the first and second level. But then when you get up to the ALJ level, that requires another add-on because you need attorney support with that, as well as physician advisor support during that time.
What do you think that cost is?
I could probably get back to you, but I would say it's a couple of $1,000s per at the ALJ level.
In addition?
In addition to.
After the first two steps,
Yes.
the third step?
We actually, we as a health system spent about $4 million just gearing up for the RAC process to add on the additional personnel it would take to manage that process.
Was that compliance and appeal?
Compliance, appeals, and medical records, and just managing and tracking the whole process, as well as software.
Thank you. Dr. Shee, do you have an estimate on the cost of an appeal on a high-value claim?
Yeah, I don't have an estimate on a single appeal, but I can say the resources our hospital puts forth in the whole auditing process. We have multiple nurse case managers that their entire job is to determine status and assist physicians in helping to determine the proper status. Once an appeal is made, we have a team of lawyers, our CMO, 2 utilization review physicians, and multiple other nurse case manager staff whose job is to fight the appeals process. So anyone looking at those numbers of staff can calculate that this is a costly endeavor to our hospital.
Okay. Did both of you hear Mr. Kavanaugh describe one solution, a short stay outlier approach. Do you have a view on whether that helps, hurts, doesn't solve the problem?
I think, you know, when we've been talking about different solutions, and obviously I think CMS did intend the 2-midnight rule to fix a problem in observation status. They recognized that there were issues with the current observation policy. I think now we've seen that the 2-midnight rule also has issues, and we would hope that there would be more consideration of policies going forward, thinking about the true definition of what observation truly means. A very short stay, a patient, a very well-defined subset of clinical needs prior to going forward and coming up with a new plan. We would also strongly advocate for a pilot. I think with the 2-midnight rule is evidence of rolling out a policy across the country with unintended consequences. I think a pilot would be of great benefit.
I would agree with that, with everything Dr. Sheehy said. One of the statements that was made earlier is that there was disparity between the cost of observation stays. And I would submit that one of the reasons for that is the true definition of what observation used to be, and that was a period of time to help determine whether or not the patient needed hospitalization as an inpatient or could be sent home. Those short stays in observation would be very less costly. By the time they need to be admitted, those are patients that require extensive diagnostic studies and intensive treatment. And sometimes those patients turn around in less than 2 days. And so we should not be penalized for being efficient in our ability to manage those patients as an inpatient.
Thank you. Ms. Edelman, you made a point that drew my attention. You were making the case that if outpatients return to the hospitals within 30 days, their return isn't a readmission because they were originally labeled as outpatient. And some portion of the reported decline in hospital readmissions reflects the fact that many patients are called outpatients. Any idea how frequent that is? What percentage of the reported decline that might represent?
We don't have data that would indicate what portion of the readmitted patients are not called readmitted because of observation. But actually, the only reason that we have ever heard from families told by the hospitals that they are using observation status is the recovery audit program. Nobody has ever actually brought up the hospital readmissions issue, but we know that that is now in effect, and so it obviously has some impact. Because if somebody returns to the hospital as an outpatient, that does not count as an inpatient, and it's not a penalty, would not be applied.
Dr. Evans, when there are costs associated with the hospital appealing, especially in high-value inpatient claims, and they are overturned, the RAC returns the commission. Is that correct?
That's correct.
Do they share in the cost of that appeal at all?
Well, the cost of our work doing that appeal and the work doing the review initially.
But having lost that claim, do you share, does the RAC reimburse some portion of the cost?
Well, we're paying back all of the funds that were used on our
that
part to do the work.
because it was an improper determination up front. But do you share in the cost? So you don't receive your commission. Do you share in the cost?
That's the financial penalty that occurs.
What?
That's the financial penalty that occurs. There's not a payment for any of the costs of the hospital. So I'm not aware of
the impact is you return the commission, but you don't share in the cost of the lost appeal.
We pay our portion of attending the appeal, and the provider pays their portion of attending.
Say that again.
We pay our portion of attending the appeal, and the provider pays their portion of attending the appeal.
Okay. Win or lose, that's how it's divided.
That's correct.
Okay.
So when we win, there's not any difference either.
Okay. And I'll finish with this. Listening to testimony today, there are an isolated number of short-stay DRGs that may be problematic. It was discussed earlier. In the oversight of the RAC program, did CMS ever intervene to stop audits so they could insert a targeted payment approach to quickly and easily solve the problem of these short-stay DRGs?
And you said a targeted DRG approach?
Yeah.
They haven't intervened. The intervention has been to stop the short-stay reviews with the 2-midnight rule, but there's not been an intervention. And I think what we've heard said today is there's a lot of variety, a lot of difference across providers in the rate of improper payment for outpatient versus inpatient care. And I think we've also seen that Is that, and we've also seen discussion that we need to look at where we go forward. So for instance, CMS is proposing in the new contract that we have a variation in the amount of medical records that are reviewed based on the provider's outcomes. So if we have a provider who has a very low rate of improper payment, we would expect to decrease as we go forward their number of records looked at. If we have a provider who has a higher rate, we would expect to increase that going forward. So CMS is looking at that. So I think what I would say is we want to collaborate with you, and I think this opportunity to share information is very good, and I look forward to be involved in continuing this sort of information exchange.
Okay, thank you, Dr. McDermott.
Thank you, Mr. Chairman. There was a senator by the name of Daniel Patrick Moynihan who said there are a lot of simple answers around, but we need a great complexifier. And the fact is that we have a very complex question here, and the next level is going to be, it seems to me, even more complex. Because you've all agreed that the patients get treated the same, whether they're observation or inpatient. The patient gets what they're supposed to get. So what we're discussing here is who pays how much to whom. And it's a question of whether the beneficiaries get charged more or the hospitals get less money, or that seems to be where we are. And one of the issues that's come up here, Ms. Edelman, that is one that I'd like to hear your thoughts about are, there has been a talk about the different cost sharing between Part A and Part B. And people are suggesting that we roll Part A and Part B together and that somehow will eliminate or alleviate or something in this whole process. I'd like to hear from you as a patient advocate what you think will happen to beneficiaries if we roll the A and B together generally, but also specifically in this outpatient, inpatient, or outpatient observation status, because I think we don't want to make another step that makes it even worse. I mean, we were trying to fix a problem with what we did. So give me your ideas.
Thank you for that question. Simplifying the program, the complex Medicare program, would be helpful. The problem with the Medicare redesign proposals that we have seen that combine Part A cost-sharing obligations is that they also prohibit other insurance like Medigap policies that provide first dollar coverage. And so the consequence is that these combined Part A, Part B cost-sharing obligations would shift costs to the patients. The idea of that is, in fact, to make people pay more out of pocket on the assumption that there'll be more careful healthcare consumers. But what we know will happen is that people will avoid medically necessary care because they won't be able to afford it. Medicare beneficiaries already spend a much higher proportion of their income on health care than younger people, and half of the Medicare beneficiaries have incomes of $23,500 a year. They really cannot afford to pay more out of pocket, which would happen as a result of a number of these redesign proposals that we've seen. Our program, with a couple of other programs, the Medicare Rights Center and California Health Advocates, submitted a statement to this committee a year ago about concerns about the Medicare redesign proposals. I'd be happy to submit that for the record.
How would the rolling of the two together affect this whole question of observation versus or would it just, there would be no question anymore, it'd just be a patient in the system?
Well, it would depend upon how the specifics of the redesign worked and how people would have to pay. Right now, if people are inpatients, they pay the inpatient deductible. If they're outpatients, they pay the full cost out of pocket for the nursing home care and Part B copayments and medications. And it's not clear what would happen with a combination of those two.
Does the 3-day stay that has to be there to go into the nursing home, what happens to that?
That's still in the statute unless that gets repealed. That's been in the Medicare statute from the beginning.
So if they're in the hospital and the hospital calls it an observation, they do not get the credit for going into the nursing home.
They do not get, the 3 midnights do not stay. So the woman in Wisconsin who was in the hospital for 13 days,
Yes.
consecutive days as an outpatient, did not have a 3-day qualifying inpatient stay.
And rolling the Part A and Part B together would not make that, would not change that.
Wouldn't change the 3 midnight rule. That is still there.
Is there, how would you design, you know what we're trying to do. How would you design what we should do at this point? Everybody's saying we should call a committee together or something, but I'd like somebody to put something on the table and say, if anybody has an idea what we should do in this situation, I'd like to hear it.
Well, for the simple issue of qualifying for skilled nursing facility care, the HR 1179 does it by just counting all the time. It doesn't deal with whether observation makes sense or doesn't make sense. It doesn't deal with recovery auditors. It doesn't deal with all of these much more complicated issues. It just says, if you've been in the hospital for 3 nights, the time should count. And I would just say when Medicare was enacted in 1965, the average length of stay in an acute care hospital for people aged 65 and over was 12+ days. The average length of stay now in the acute care hospital for people 65 and over is 5+ days. So it's really not, the 3 midnight rule is a problem considering how medicine is practiced today.
Thank you.
Thank you. Mr. Gerlach.
Thank you, Mr. Chairman. Ms. Deutschendorf, in your testimony, you basically say that the 2 midnight policy now requires physicians to abandon the medical assessment component of the medical necessity test when determining the appropriate setting of care, and instead imposes a rigid time-based approach. Can you elaborate or expand on that a bit?
So for our providers, what happens now is the patient presents to the emergency department, and now they're faced with this question: do you expect that the time this patient will require hospital services will be greater than 2 midnights, which to Dr. Sheehy's point could be depending on whether that patient arrives 1 minute before midnight on the first midnight and then stays 24 hours and 1 minute in the second midnight, or whether they would need to be hospitalized for up to 48 hours. A lot can happen in 48 hours, and what we have found since October 1st is that we have tripled the amount of patients who have started out as an outpatient and has been converted to an inpatient after or just before the second midnight because, in fact, we got it wrong. Because we really don't know. Patients present to the emergency department with a myriad of problems, some of which are going to respond rapidly, some of which will not respond rapidly. And there's no way of knowing that, and we're doing the right things. We do have an army of case managers and utilization management nurses who now have to run around the hospital looking for patients who've crossed the first midnight to see if these patients will require medically necessary services beyond the second midnight so that we can get them converted. We have been instructed by CMS that if the patient is going to cross the second midnight, they want them to be converted, even if they're going to go home in the next 12 hours. It's logistically a very difficult policy to implement and has required a lot of financial increases as a result of that.
HR 3698 would require the Secretary of HHS to establish a new methodology for utilization in situations involving the shorter stays in hospitals. We got some idea from Ms. Edelman about what she'd like to see relative to that kind of new methodology. Could I have quickly the other 3 of you please give us your thoughts as a follow-up to Mr. McDermott's question? What specifically, change-wise, and what kind of new methodology ought to be employed so that there's a fairness, an equity in terms of how hospitals are reimbursed for those that come in a very short stay kind of situation? Dr. Sheehy, can we start with you?
Yeah, thank you for that question. I think it's a very complicated topic, and I think a simple answer is probably difficult to give. I think getting back to the principles of observation being a triaging definition, it was always meant to be a definition where someone needed a few additional hours to determine whether they should be fully admitted as an inpatient or discharged home. I think we need to get back to the principles of that definition and come up with a methodology that respects that definition. I think we also need to think about the difficulty as a provider. I have telling a patient who's staying overnight in a hospital, getting inpatient nursing care, getting intravenous medications and tests in a hospital setting, how I can explain that to that patient that they are an outpatient. I think getting back to the heart of what observation really means, I think is what we need to focus on coming up with a new policy.
And then you added to, you thought that should be done on a pilot basis first to really test the idea, to see if it really in a practical way is working before expanded to the entire system?
That is correct. I think we will see the unintended consequences of any policy. I think we'll understand better how a policy should be audited and do it on a smaller scale, so hospitals across the country are not investing a lot of money on a whole new plan that has a lot of issues. We can figure out those issues and tweak the plan before it's implemented nationwide.
Dr. Evans, do you have a quick answer to that, even though you would look at it from the RAC perspective?
Well, as far as from the RAC perspective, I've said I think the collaboration, the discussion is very good, and I think that the idea that there's some changes that can be made are good. If there were a pilot, we'd be willing to be involved in that. I would say I'm here for the recovery audit work, but I'm very interested in this personally. If after the meeting or something you wanted to talk with me as a taxpayer, I'm a physician.
You're not having heart palpitations right now or anything.
No,
That's why
I'm
you're
not. I'm
interested
fine.
in
I
it.
love this. I think it's really excellent to have this discussion. It's what I'm doing my work for, so that this would sort of happen. And I'm running over. Okay, I just wanted to say I've been medical director of skilled nursing facilities, worked at the MAC, and now at the HDI, and I've got a lot of ideas, but I think we would support this type of reform, and we could offer, discussion and support afterwards. Thank you.
Thank you, Mr. Kine.
Thank you, Mr. Chairman, and I want to thank our panelists for an excellent presentation today. And Dr. Shea, a special welcome to you. I've had the opportunity back home to visit the UW hospital system and the clinics. I've always been very impressed with the quality of care, the outcome, the measurements that are being established back home. But you're probably sensing a source of frustration coming from this dais. This is some tough, complicated stuff, and we're trying to wrap our head around it. And we're listening to you try to thread the needle on the different statuses and observation, inpatient, outpatient. As policymakers, we're going to have a hard time being able to provide direction at this level of expertise or knowledge that's required of it. And it's really kind of the source of frustration that we have with the overall healthcare payment system that we have in our country today. It's this fee-for-service, it's this coding, it's this payment based on how much is done, not how well it's being done. And there are tools in place right now, and many of us have been pushing hard and been very impatient to move to a more value, quality, outcome-based reimbursement system. And if we can get those financial incentives, I think, aligned right, we're going to unleash a heck of a lot of innovation in the healthcare system, knowing what those benchmarks need to be, where those measurements are, and then figuring out a way to how to meet them. Because the truth is, we don't have so much a budget deficit problem here in Washington as we have a healthcare spending problem. And that's what we're wrestling with. And there are only a few options that we can go down the road with. One is greater cost shifting, having patients bear more of the risk of higher costs. We see that with voucher proposals or what have you. Or you're going to have some indiscriminate provider cuts being made. And the provider community obviously isn't going to be very happy with that. We see this through sequestration and pushing those hospital cuts out for infinity, it seems, at this point. Or we need to be working with the provider community to establish those quality measurements and then align the financial incentives so it is value-based and no longer observational status or all these technical definitions that just weigh us down. And it's just exhausting, having these conversations and getting the feedback from patients and providers alike. So I guess just a general question. Dr. Shea, I can start with you if anyone else wants to chime in. Ideally, where do we need to be going with the healthcare payment system of this country right now so that we're not having hearings like this talking about inpatient or outpatient or observational status and trying to figure out what the best policy is in addressing it?
Well, thank you for the question, and thank you for all the work you do for the state of Wisconsin on healthcare. I would be more than happy to work with you in the future on these issues going forward. I think it is very complicated. I think there's certainly a role for quality measures in physician payment, and I think as hospitalists, we're trying to figure out exactly how we fit into that payment model. Going forward, though, I think, you know, I'm from a small town in Wisconsin as well. I grew up near Madison where I work, and what I do on a daily basis is take care of patients in the hospital. Some of these patients might have been my neighbors or maybe a middle school teacher. And I think if we can get back to thinking about, you know, these are Medicare patients, they've worked their whole lives, and what is the right thing to do for them, I think we're going to find those solutions.
Yeah. Ms. Edelman, I am concerned about the impact on the beneficiaries, the patients out there. It seems like they're getting caught. I mean, they're often not to their knowledge and just based on definitions that are applied to them, and then the increased out-of-pocket expenses that they're experiencing, which creates a tremendous hardship. And yet, within the Medicare system itself, we've seen per beneficiary payments come down dramatically in recent years, and hopefully that's sustainable. And hopefully that's due to some of the reforms that are taking place with the delivery system, but also some of the new payment models out there. But how much concern do you have right now in regards to the cost shift that you're seeing with the beneficiary community?
The cost shifting in the observation status is considerable, and we know that some people really do not have the money to pay for the nursing home care out of pocket when they're told what the cost is, and they go home. And then what we hear is a couple of days later, they have another fall, they break a hip, they're back in the hospital. So the costs to the system are very intense. We know families are contributing huge amounts of money to pay for out-of-pocket costs because Medicare is not paying for the nursing home. So we've heard of a nephew being asked to bring a check to the nursing home today for $7,000 for his aunt to get care. People are doing that. Families are kicking in money that they may not really have. We've heard of families cashing in life insurance policies that were intended for burials because they need to get the nursing home care. So it's having a tremendous impact on Medicare beneficiaries and their families trying to pay these high costs. The average private rates are like $250 a day, but I was in a nursing home in Boston last month, and the private rates were $450 to $480 a day. Most people can't pay that.
Thank you. Thank you, Mr. Chairman.
Thank you, Mr. Smith.
Thank you. Thank you, Mr. Chairman. Ms. Deutschendorf, in your written testimony, you referenced the Medicare Audit Improvement Act, H.R. 1250, obviously supported by numerous members of the House. Wondering if you could reflect a bit on an alternative, which I happen to introduce, H.R. 2329, the Administrative Relief and Accurate Medicare Payments Act. Have you reviewed that bill, and could you reflect on that at all?
I have not, but I would be happy to respond in writing.
All right, you bet. Thank you very much. Ms. Edelman, what do you believe is the cost? Well, first of all, do you believe that Medicare beneficiaries are very familiar with the financing or the various, I mean, we've heard a lot of technical things. I started to keep a list here and I lost it amidst the paperwork here of just terminology and funding strategies and schedules of payments and so forth. How familiar are seniors with that type of thing?
I think most people have no idea of what the terminology is or what it means.
And do you believe that there is a cost to that, given the existence of that disconnect with patients? And I mean, I don't believe we could really expect them to be familiar with all of these intricate details of a funding system. Is there any possible way just to have a system to where seniors are more familiar with what's going on with the funding, so that not that it has to be out of pocket, but so that they can perhaps know more what their options are? I mean, as you pointed out in your testimony, you know, that they were considered an outpatient, but yet they were in the hospital for so long and certainly thought that they were an inpatient. What do you think the alternatives should be?
Well, there are some some bills that would suggest giving information to people to tell them, at least give them that information that they're outpatients. And a couple of states have passed laws, Maryland and New York, requiring that people be informed that they are outpatients and what the consequence is. But unlike other Medicare systems, they don't have an opportunity to have to contest their outpatient status. Generally, if somebody goes into the hospital as an inpatient, person immediately gets a form, your rights as a Medicare patient. And if the hospital wants to discharge the person and the person thinks, I'm really not ready to go, there's an immediate appeal to a representative of the Medicare program to make a decision. In observation status, there is no due process right for the Medicare patients. There's nothing they can do. So giving them information is helpful, but we also need to give them an opportunity to say, I should be called an inpatient, not an outpatient.
Mm-hmm. Would you agree that the more the government has gotten involved, that the more expensive health care has become?
Well, I don't know if the cost of the government has been the cause of healthcare becoming expensive. Certainly before the government was involved, a lot of people didn't get health care, and so it's been critically important. Medicare is a very important program for older people, and most older people love their Medicare program.
Sure.
Without it, they wouldn't get the health care they need.
Okay. Thank you, Mr. Chairman. I yield back.
Mr. Pascal.
Mr. Chairman, I'd like to just make a couple of points in response to my friend Mr. Roskam's comments in the last panel about state budget neutrality, which is interesting to define, and how it affects what we're talking about. New Jersey is in a unique position because my state is an all urban state with no rural or critical access hospitals. I'd like to point out that the permanent adjustments have always been based on the national budget neutrality, always. So this includes adjustments for critical access hospitals. And there ironically are 53 critical access hospitals in Mr. Roskam's state of Illinois. I think we need to make that clear. Now, Ms. Edelman, your organization has done a significant amount of work in the area of observation stays, and you worked directly with the number of beneficiaries who have run into problems with the way they were classified. I think you defined that. In your experience, do beneficiaries generally know whether they are classified as inpatients or under observation status, in your experience?
Most patients do not know that they are in observation, and the Medicare program does not require hospitals to tell them. The only
Do they have a right to know that?
Well, they should have a right to know it. Yes, they should. They
Okay,
should
now,
know in the consequence.
when do patients generally find out what their status is?
Usually at the time of discharge. They're
When they
told,
pay their bills?
bring the checkbook to the nursing home because
what I
Medicare will
figured.
not be paying.
You mentioned earlier observation status is particularly problematic when Medicare beneficiaries need care in a skilled nursing facility after leaving the hospital. Because Medicare won't cover these services unless a patient has been classified as an inpatient for at least 3 days. Am I right so far?
Yes.
Ms. Edelman, in the cases your organization has handled, what is happening to observation status patients in need of care at a skilled nursing facility after leaving the hospital?
Some are not going because they can't afford it. Some are going and paying out of pocket and trying to appeal later through the Medicare summary notice form that they get, trying to appeal through the administrative process. But many of the people I've spoken to do not pursue the appeals. They give up. It's just too complicated and too time-consuming, and they give up.
Are many of these seniors paying out of pocket?
Yes, they're paying out of pocket, and their families are as well.
So, Mr. Chairman, in conclusion, if we don't identify and respect the right to know, and we had a Patient's Bill of Rights, which is part of the reform process that we are now going through, then we defeat the purpose of what we're doing. Seniors, anybody, has a right to know what status they're in, what that implies, and how much it's going to cost them eventually if they don't get out of that status or if they don't cross over. I think that this is serious business. I ask you to bring us to attend to it. And there's legislation here which is bipartisan, and I hope that you'll do that, and thank you for the hearing.
Thank you. Mr. Renacci.
Thank you, Mr. Chairman, and thank the panel for being here. You know, it's interesting because I think we're really talking about a problem, and then there's the symptoms of the problem. The problem is the hospital readmission reduction program, and quite frankly, the policy that was written was probably, the thought was good, the outcomes are becoming bad, because when a patient enters the hospital, they're either classified as observation, they're not admitted. I mean, there's all kind of things. They're outpatients, so we're putting them in classifications. Why? Because we don't want to be penalized for the reduction program if you're in the hospital. And again, I'm not blaming the hospitals in that sense. I'm saying they're trying to survive too, but quite frankly, who's getting hurt here but the patient? So let's look at the unintended consequences. We have patients that go into a hospital. They're the sickest of sick. We know they're coming back, and we have an issue there. It's one of the reasons why I introduced H.R. 4188, a bill that requires the Secretary of HHS to adjust the payment methodology to account for certain disparities really in patient population. This adjustment will really make a huge difference to hospitals across the country, and the 9 million dually eligible beneficiaries rely on these hospitals for the critical care needs. We need to make sure there are patients that are going to come into a hospital that are going to go back to the hospital. And those hospitals are being penalized. This bill would at least help that issue. Now, on the other side, I still have a problem when you take a patient who, quite frankly, doesn't need to go to a hospital, should be going directly to the nursing home. But we have another policy that says you have to go to the hospital first, and you have to spend 3 days in that hospital. And then that patient goes to that hospital, and of course, they spend 3 days. They don't know whether they're observation. They don't know whether they're inpatient. And then they come out, they go to a nursing home, and then they're penalized because in many cases, they ended up as an observation status. That's a problem too. That's why we talked earlier about the bill I introduced to really eliminate the 3-day stay. I don't know why we're paying. Now, let's face it, there are some patients that have to go in the hospital, but there are some that could go directly to the nursing home. And I question why we would ever be paying, up to $11,000 to have someone stay in a hospital for 3 days versus going into a nursing home where my statistics show the average stay is around 27 days. Quite frankly, it doesn't make sense. We're spending money that's not necessary. But Mrs. Edelman, I would ask you, do you think the elimination of the 3-day hospital stay is good policy?
Well, I think it ultimately is what makes sense, because I said the length of stay in hospitals has gone down so much that the 3 days is a very large portion of what time people actually do spend in the hospital. The Long-Term Care Commission endorsed elimination of the 3-day stay. And so this is where I think, as Congress is considering post-acute care reforms, which is a topic of discussion now, this should certainly be part of the discussion. We want to make sure that that there's not a lot of gaming in nursing homes, so we want to be careful of that possibility, but this is where it needs to go to eliminate it. It doesn't make sense with the way medicine is practiced today.
And I don't know if there's anyone else on the panel that, when we talk about H.R. 4188, which is the bill that really takes a look at these hospitals where there are readmissions for the sickest of sick, the poorest of poor, if we shouldn't have, we shouldn't have an adjustment for those. Is there anyone?
So, as I stated in my opening comments, and thank you for asking, I'm responsible for the readmission reduction program for the Johns Hopkins Health System and our hospital. We've been at this for 4 years, and we are working really, really hard to implement all of the strategies that were suggested in the demonstration projects. And at an academic center such as ours, where we take care of some of the sickest patients in the country who are transplants, who are dually eligible, et cetera, we have not been able to move that ball. And in fact, with the, it's all about numerators and denominators, but as you take out the short stays out of the denominator and your patients are sicker, your readmission rates go up. Despite what we're doing, and we do have some successes, but we have not been able to move that. So having that bill with taking out transplants, end-stage renal disease, substance abuse, and psychoses, and some of the other things would certainly help us. The other thing that we've really learned about this has to do with patients' values, beliefs, and preferences. So it's very important that we share this responsibility, not just with the providers, but also the patients.
Thank you. Mr. Chairman, I yield back.
Thank you, Mr. Reed.
Thank you, Mr. Chairman. I'm way over here, so I appreciate give you a different angle here to look at. I wanted to come today and thank you, Mr. Chairman, for holding this hearing, and thank you to the panelists. This is something that I'm very concerned about. Coming from a rural section of the state of New York, my rural hospitals in particular are struggling to deal with these issues as well as many others. And I wanted to just read for the record a letter I received from one of our hospital directors at Jones Memorial Hospital in Wellsville, New York. She wrote, Dear Tom, Jones Memorial is a sole community hospital in rural upstate Western New York. Jones has an average daily census of 20 patients. As many rural New York State hospitals, Jones has limited resources and actively trying to keep costs down to the overall healthcare system. Then she goes on. She writes, in 2012, Jones began receiving RAC program audit notices. Cases dated back to 2009. They received a total of 240 inpatient claim denials. To date, Jones have appealed and won approximately 197 of those claims. Of the 240 claims, 18 were not successful on appeal. The rest of the cases are still pending. So pretty good outcome in regards to challenging these requests. But this is what she says that really stuck out to me in the letter. Jones Memorial, with an average daily census of 20, has to employ 3 full-time RN case managers to make sure that someone is here the majority of the time to assure compliance with the 2-midnight rule. These same case managers expend a lot of their time working on appeals for the RAC audits. We also have 3 billing and medical record staff that spend 30% of their time on RAC audits and appeals. The dollars being expended for a small hospital are unsustainable. Now, when I hear Eva write me that letter, and I know Eva very well, Eva Benedict does a great job there at Jones Memorial, my concern is this: how are these rural hospitals going to sustain themselves if they have to take on those administrative cost burdens that we just articulated there and keep the doors open and comply with this complexity coming out of Washington, D.C.? Do you share with me, anyone on the panel disagree with me, that in particular our rural hospitals are at a distinct threat as a result of the burdens that are coming out of this ambiguity? Dr. Shea?
I can answer that question. My primary practice location is at University of Wisconsin Hospital, which is a tertiary care referral hospital, but I also am privileged at one of our community hospitals and practice there. It's a small hospital. And I agree with you. I think that the burden on smaller hospitals is enormous. I also think a lot of these smaller hospitals have contracted with, there are private companies now who will actually do what your hospital has described. Instead of hiring their own case managers, nurse case managers to do this, they'll hire a private company and pay them a lot of money to look at these claims for them. And I think the cost is enormous. The cost to fight this process and to kind of learn how to do these audits and appeals, it's staggering.
Anyone else share that sentiment or oppose that sentiment? Because I agree with you. And those are dollars that otherwise could be going to the community in regards to servicing their healthcare needs as opposed to complying with administrative burdens. Do you have any idea, here's a hospital with 20 average daily census, and they got essentially 5 full-time workers focused on filling out paperwork. How can we do better? Yeah, ma'am.
I just want to say one thing about that hospitals are spending an enormous amount of time and money trying to make these inpatient, outpatient decisions. The first thing they do is buy IntraQual, which is a proprietary computer program. Then they are hiring staff just to make these decisions. And the American Case Management Association, which is part of our ad hoc coalition supporting HR 1179, did a survey of their members. These are the hospital discharge planners. 3/4 of the hospitals reported hiring staff just to be making inpatient, outpatient medical necessity decisions. 1/3 of them had spent more than $150,000, this is a couple of years ago, on that staff. And then they're also using an outside secondary reviewer. The company that we know of used to report on its website how many medical necessity cases they had done. Since 1997, they had done 4 million. If they're charging, we think, maybe $200, $250 a case, that is a lot of money to go out of the system, out of the Medicare system, which should be designed for providing care to people. But it's only to make the decision whether people should be admitted as inpatients or called outpatients, and the care is identical. It really makes no sense.
Thank you. I yield. My balance has expired, and I thank you for that input.
Thank you, Ms. Black.
Thank you, Mr. Chairman. Again, thank you for allowing me to sit here with the committee and ask questions. I want to go back to the issue of the ALJs and the amount of overturned cases. And we just hear, I know this is a complex situation, and we hear these numbers that keep floating around, and there is a report that I want to submit for the record, and it is from the Inspector General. The improvements are needed at the administrative law judge level of Medicare appeals, because there are some good pieces in here as well. But Dr. Evans, I want to start with you on this question, because our members are hearing at least 70% number that the providers win these appeals at the ALJ level. I understand that there are 2 different ways that the ALJ adjudicates cases, and can you please explain how the RAC's view of the overturn rate and how these numbers can deceive when looked at out of context?
Yes, the report you refer to, the data that's in there is from 2010, and that was early on in the recovery audit program. Now, I haven't done the analysis, and I would say that I think it's good that this is brought up here, and I think there's some further investigation of the data that can be done among the different experts like OIG, et cetera. But that data is from 2010, and at that time, we were getting no information about any kind of ALJ hearings. We had attended a few in the demonstration, but we weren't hearing, and we were asking about those. What we found out was that they were 89, 90%. The AdQuick has that information, but they were huge numbers. They were on the record. The on the record in general is a high overturn rate. It's pretty much, they're all overturned. All of the contractors across CMS have data that shows that, and in fact, CMS had done a study with one of the contractors where the attendance of CMS at the hearing makes a difference in the outcome of those hearings, where the Medicare rules and regulations and the medical record compared to the claim is reviewed. So I think it's an area that we can be looked at, but I think that's part of the difficulty. If you look at the last study, the 7% overturn across the board is the most current data that we have.
Could those who are providers weigh in on this from your perspective as well, of your cases that get to the ALJ level? Dr. Sheehy, let me go with you first.
Well, thank you for that question. So we have little data on our ALJ level 3 appeals at this time. The majority of our appeals are turned over in level 1 or level 2. I will just comment that I think the 2010 data is, I think the RAC process and observation care has evolved so enormously in the last 4 years that I think it's worth looking at a new set of data and a new set of numbers. We know that the RAC recovery rate, the recovery rate for back to the government has increased. We know that the number of RAC audits have increased. This is why the OMHA has now put a hold on further audits and appeals. We know this is a lot due to RAC denials. And so I think we really do need to look at a fresh set of numbers before we start thinking about a 7% number. I can speak on behalf of our hospital. We We appeal almost everything, and we win almost everything. The number that I cited in my testimony, we appealed in our last 1 year, we appealed 92% of the audits that the RACs made, and we've already won 2/3 of them. The rest are in level 1 or level 2 of appeals. So our history is that we will win almost 100% of our appeals. I think there are a lot of hospitals out there that are similar.
Well, that's a good piece of information. Thank you so much. Others want to weigh in on that? Yes.
So we do not have any, we just have 10 cases at the ALJ level that have just made it there, and part of that has to do with the delay in the actual recoupment. So we were able to take 239 cases of our 430-some denials directly for discussion, and we spent a lot of time preparing with legal and also with our physician advisors, and went straight to the medical directors of our RAC, and 135 of those cases were overturned just at the discussion, and the remainder of those are in the appeal process now. So that's a 50% or 55% overturn rate just at the discussion level. I just want to say one other thing. We had 108 cases denied for intensity modified radiation therapy. All 108 of those cases were overturned at the discussion level, again, because these were medically necessary services that the RAC really was not able to really understand why these cases were brought forward.
Thank you. And Mr. Chairman, thank you so much for this hearing. It just seems to me that one of the things that I have learned from this hearing is that this certainly needs to have more oversight, more investigation to find out just how the program is working, because I am so concerned, as being a nurse for over 40 years, that the care that we're giving, and Dr. Sheehy, please, every time you give a testimony, use that example of a diabetic ketoacidosis, because it is so compelling to make the case for how you just don't know what that patient's going to need when you receive them into the hospital. But thank you so much, Mr. Chairman. I look forward to more hearings.
Thank you, Ms. Black. I just, an inquiry, again, thank you for all the witnesses. In the first panel, again, from Dr. Evans, we heard repeatedly the RAC audits aren't a problem. 94% are not appealed. Of those who are, only about half are overturned. Percentage-wise, this is a very small amount, not a big problem. That's at odds with what we hear from our local hospitals in a major way. And what I think I just heard from Dr. Sheehy and Ms. Duchendorf is that that's old data, that current appeals are much greater than that, and the overturn rate is substantial as well. And while they may be a small percentage, these are more of the high-value claims, so proportionally more important, probably more expensive to appeal. Is that correct? In a nutshell? Well, what else, what other perspective should we bring to this?
I think that's a correct assessment. Just another data point in the OMHA letter to hospitals, one of the numbers they cited, which I think is why I think this is old data, they said in January of 2012, the OMHA was hearing about 1,250 appeals a week, and at the end of 2013, they were getting 15,000. So I think the rate has just accelerated over 2 years, and I think that number tells you how audits have changed, how our practice has changed.
Because the Inspector General's report was from 10 and 2011. You're saying accelerate. Ms. Duchendorf?
So I would agree with that the appeals have mounted as hospitals have been able to change their processes, and also that they have rigorous utilization processes, that they're also ensuring that they're meeting the compliance and meeting the regulatory requirements for Medicare review of inpatient stays. We, in our compliance program, we self-deny almost $4 million a year in Medicare days that we feel we cannot justify for medical necessity. So we feel that anything that we appeal is justifiable. So anything that's denied by RAC, we will appeal.
Got it. Dr. McDermott?
I'm like you, a little bit confused by what I'm hearing here, but it seems like what you're saying is that the RACs operate like the fishermen in my district. They go out and throw a great big net, and they bring in that's where the 12,000, you jump from 1,500 at the end of one year to 12,000 in the next one. So you've caught a lot of stuff in there, most of which turns out to be not justified. Is that because they're going on volume? You're saying that the racks are going on volume, and they got a lot of bycatch, and they have to throw it back because it doesn't work.
That's exactly right. They cast a very broad net, and then what is really considered improper, we would respectfully disagree that those are not improper payments, and we're appealing all of them. So we're appealing 92%. It's almost exactly the same with Dr. Sheehy has said.
Thank you.
If I could just say one thing, if it's so complicated for hospitals to do these appeals, you can imagine what it's like for beneficiaries doing it on their own. There's one gentleman from Chicago that I talk to every couple of months, and he's in his 80s. He's homebound. The last conversation we had, he was describing his cancer and the therapy he's having, and he's trying to do this appeal for his wife. It's very difficult for beneficiaries, if they even get to that stage, to appeal their outpatient status.
Yep. Thank you. On behalf of Dr. McDermott, I'd like to thank our witnesses for their testimony today and appreciate the continued assistance getting answers to the questions were asked by the committee. These are challenging issues, interrelated, facing CMS, this committee, and our hospital providers. My view is we have to address them head on in order to ensure seniors are treated fairly and do not face unnecessary charges. And it's equally important for providers and taxpayers to get these issues straightened out. So I look forward to working with all the witnesses and members of the committee to do just this. As a reminder, any member wishing to submit a question for the record will have 14 days to do so. And if any questions are submitted to the witnesses, I ask that the witnesses respond in a timely manner. With that, subcommittee is adjourned. Good. Thank you.